So it is like a case-based discussion, and I will ask various panelists about what they will do in this particular case and situation. And in that process, we intend to convey the messages to the viewers. Dr. Gul, welcome. Where are you sitting, man?
Welcome, Ashish.
Ashish, what is that background?
I'm changing it. That was the morning webinar.
નવીન ભાઈ તમારાથી વધારે બીજી કોઈ છે વેબિનારમાં?
Yes, everybody is busy. Yeah? Okay, I'm starting, huh?
Okay.
We are thankful to all the faculty for accepting our invitation of Gujarat Orthopedic Association, and we are very much thankful to all the faculty. And for the viewers, we are thankful very much for continuously watching our webinars of Gujarat Orthopedic Association. And this is 42nd webinar, and previous all 41 webinars are available on this recording link. If you click this link, you will get all 41 webinars ready there for your ready reference. So just click this link. As you go down, just click this red arrow and you will be there in this today's webinar of GCT, giant cell tumor, everything about GCT. You will learn from the all masters. All are masters or onco-orthosurgeons, and you will learn case-based learning will be there. And during that period, if you have any question, just click here in the Slido window and put your question. I have limited to 160 characters just to make the questions crisp, so we can come to know what you want to ask. Those who have problem and those who are ringing from the seeing from the mobile device, they have a button of ask. Just click the button of ask. Bolo. And then just click that. The question will come to me. Please close the mobile. Please close the mobile. Then mute yourself, please. Mute yourself, please. And those who are seeing from the mobile has the problem of texting. They can record audio and or video and just click on WhatsApp Navin. It will come to me and I will hand over to moderator, faculty whenever it is required. So your questions will be answered in between when the faculty is discussing already. So I may pose the moderator to give the answer to the audience. Let me introduce the faculty. Dr. Mandip Shah is an onco-orthosurgeon here at Ahmedabad. He will be moderating. And you all know Dr. Manish Agrawal. He is a very famous onco-orthosurgeon from the Mumbai. Welcome, sir. Dr. Jyotindra Pandit, our own onco-orthosurgeon and a general orthopedic surgeon, both, who had started with the Dr. M.T. Mehta, sir, at Cancer Hospital Onco-Ortho branch here. And he is also past president of Gujarat Orthopedic Association. We have today special guest, Dr. Sudhir Kapoor, who is the past president of Indian Orthopedic Association, and he will be sharing his own case of giant cell tumor. So we'll be having a new experience or new sharing from him. Dr. Ashish Gulia, everybody knows him, Professor Ashish Gulia. Dr. Chetan Achin, again from Mumbai. Dr. Yogesh will be joining shortly. He is busy in one emergency. Dr. Kundu is also busy in the meeting, but he will be joining shortly. Dr. Alok Agrawal is from Raipur, and he'll be sharing his case of the proximal humerus GCT. So we'll be having a different experience from different states and different material. Dr. Jaimin Shah and Dr. Abhijit Salunke. Abhijit is joining just now. They are the onco-orthosurgeon. And we have a very young onco-ortho surgeon from Bangalore. And we have a very experienced general orthopedic surgeon who is also a general surgeon, MS, general surgeon and general orthopedic surgeon, who has done a lot of onco-ortho work in a remote place of Chandrapur. And he will be sharing his case of giant cell tumor, probably lower end radius. So we will have a very varied experience of the giant cell tumor, and I will be just coordinating you and putting a link between you and audience. So Mandeep, now you can take over the screen. I'm
Sure.
stopping the sharing. Okay.
Yeah. All right. Am I visible? I mean, the presentation is visible?
Yes.
No.
Not yet.
No. It is there.
Full
It is there. Sorry. My screen was different. It is there. Just make it full.
Okay. All right. Shall we start?
Yeah.
Okay. Good evening, viewers. Thank you, Navin Bhai. Thank you, Gujarat Orthopedic Association, for hosting this webinar. And special thanks to all my faculty for agreeing to join us. And we'll certainly learn from your vast experience. Dr. Thakkar has already introduced all the faculties, and there are some names who really don't need any introduction. Dr. Manish Agarwal, but I will have to introduce him as my mentor because I have trained with him long back at Tata Memorial Hospital, and of course we'll keep on learning from him. Dr. Pandit, again, again I would call him as my mentor in Ahmedabad. Dr. Gulia, a very close friend, and I think the torchbearer or rising star of orthopedic oncology in the country. Yogesh, again, a very close friend, currently secretary of IMSOS and the chief editor of JBST. Chetan, a very dear friend, my colleague from Mumbai. Dr. Kapoor, Dr. Thakkar has already introduced him. Srinivas, again, a very close friend, a colleague from Tata Memorial Hospital from old days, 2005, 6, 7. Dr. Kundu will be joining us from Rohtak. Dr. Alok, I remember the days when you came to TMH as an observer in 2005, and we had really good time. And I am glad that you have continued your passion for oncology. Dr. Gadgane, I have been interacting with him off late because of thanks to Dr. Thakkar, and really is giving new insights into what we really don't practice. Abhijit and Jamin, they are my fellow colleagues from Ahmedabad. So this is how we are going to discuss all these things. We are going to discuss in cases. We are going to discuss a little bit about basics, then curettage technique and controversies surrounding adjuvants, how to reconstruct a giant cell tumor cavity, denosumab, whether it's a magic bullet, and what to do when the giant cell tumor is not curatable. And then we'll have interesting cases from Dr. Kapoor, Dr. Agarwal, and Dr. Kundu and Dr. Gadgone in between. So let's get started. So first I'll ask my faculties, which of these is a giant cell tumor, or all of these are giant cell tumor? Jamin, what do you think? Which one of these is giant cell tumor? Unmute yourself. Unmute yourself.
Am I audible?
Yes. Which one is the giant cell?
So the classical radiological picture of a giant cell tumor as described is an eccentric, expansile, epiphyseal, so bubble
that
lesion.
will come from these five. Which you think is giant cell?
So from all these cases, they all can be a giant cell tumor.
Okay, they all can be giant cell tumor.
Yes.
All right, Ashish, which one you think is a GCT? Ashish, are you there? Ashish, are you there?
Hi, Mandeep. Sorry. Yeah.
Ashish, which one of these you think is a GCT?
None of them.
None of them.
Yeah.
Wow.
No, I think the point which Dr. Shah wants to make is that these tumors, which looks pretty benign, and they are the differential of giant cell tumor. While if you really look into this X-ray very carefully, then you may find that there are certain features which overlap with giant cell tumor and some other tumors as well. So they can be giant cell tumors, but
Okay.
I've seen your presentation earlier.
So you are biased. All right, no problem. So maybe Dr. Kapoor, what do you think?
I'm seeing all the X-rays. They can be in the DD, Nobody on the earth can be 100% sure
Yes.
whether it's
All
the
right.
APC or DD or something else. But they definitely, all 5 of them fit into DD.
All right.
Except probably a Laurent female looks little, well, anyhow, it's very difficult to say.
Right. So
Yeah.
yeah, just to put forward the point, the first one is an aneurysmal bone cyst. The second one is an intraosseous lipoma. This one is the desmoplastic fibroma. This one is a benign fibrous histiocytoma, and this one is a hemangiopericytoma. Now let us see these 4 X-rays. Pandit sir, which one of these you think is a giant cell tumor?
Maybe the lower end femur on the
Okay, so this one.
yes,
All right.
possibly, yes.
All right. And what do you think, Alok? Dr. Alok Agarwal, which one you think is likely to be a giant cell tumor? Alok, Dr. Agarwal is there? Dr. Alok?
Yeah, he is there already. He may be muted himself.
Okay.
Alok,
Dr.
unmute.
Alok Agarwal, please unmute yourself.
Yeah. Go ahead now.
Okay.
I have unmuted it.
Yeah. So you can see in the middle picture,
This one.
yeah,
Hmm.
there is an osteolytic destruction in the lower part, and it is not a site for any other secondaries. Although it is not having a very good picture, but the DD of GCT can definitely come. For me,
Okay.
all of them come as a DD for GCT.
All right. So this one was thyroid metastasis. This one is a non-Hodgkin's lymphoma. This one is a plasmacytoma. And this one is a renal cell carcinoma metastasis.
Right.
Okay. So now these 3 pictures. All right. Chetan, what do you think? These 3 pictures.
Mandeep, you started Viva, huh?
So this is a viva, sir. This is how the panel discussion goes,
એને અત્યારે study કરવાનો ટાઈમ પડે છે કરી લેવા દે એના સાહેબોની study કરવા.
At least the first 2 don't look like GCT.
These 2, these and these don't look like GCT.
Don't
Okay.
look like.
Yeah, because they don't reach the articular cartilage.
Yeah, exactly. It doesn't have the classic feature. Third one, I don't know because we don't have the API, but it could be.
The physis is open, Chetan.
But the growth plate looks like it's open. It will be better, seen in the AP view. So if that is open, then it is also unlikely to be GCT.
So yeah, so all 3 of these are osteosarcomas. Okay. Srinivas, you want to take this one? Which one of these you think is a giant cell tumor? All of them, none of them, one of them, 2 of them?
Just by seeing an X-ray, I don't think I'll be able to comment on the diagnosis, but it could fall into GCT could be one of the differential diagnoses.
Okay. So the first and third are chondrosarcomas, and the middle one is a malignant fibrous histiocytoma of bone. And what about these 4? Ashish, you can take this.
They are giant cell tumors.
Yeah, so unless proved otherwise, radiologically they looks like giant cell tumor. But having said that, again, there have been we have been doing a lot of classes, and thanks to all the platforms, and again to this platform as well, to again propagate the same thing, that irrespective how the imaging looks, I think we should not be biased towards radiology, and we should do a histopathological diagnosis and then take it as confirmed. But yes, these looks like giant cell tumors on radiology.
So yeah, so all 4 of them were actually giant cell tumors. Okay, Navin bhai, only one of these, out of these 8 images, 7 are confirmed GCTs and the 8th one is not a GCT. Can you say which one may not be a GCT?
Can I say something?
Yes,
Ashish.
I can see it.
Naveen bhai, next time will not make you a moderator.
No issue, sir. I may be wrong. I am not an expert. I may be wrong.
He's only
these
taking
may be
Viva.
probably.
Sitting ideally, he's only taking Viva.
All right.
Just I marked. Probably, huh?
Yeah. So I mean, see, even I could not say when these images, came to me. If someone had asked me which one of these. So basically, in these 8 images, this one, the last one is non-Hodgkin's lymphoma. All others are giant cell tumor. The idea of putting these first 5 slides is that every lytic lesion is not a GCT. Because this is a common practice or common myth that prevails in lot of surgeons' minds, that any giant cell tumor, any tumor around the joint, lytic lesion is a giant cell tumor. and workup and biopsy are mandatory. We have Dr. Manish Agarwal with us. Dr. Agarwal, sir, with around 2.5 decades of experience, before we start our first case, you want to put forward some message considering this few slides which I have just shown.
I think the most important part is not to try to make a histological diagnosis when you look at an X-ray. I think what a surgeon needs to do is try and understand, am I dealing with an aggressive lesion or am I dealing with something which is relatively low grade or benign and non-aggressive? I don't think you can tell the histology on, a lot of benign tumors may look like GCT and a lot of osteosarcomas can look like GCT. But a lot of GCTs can look like osteosarcoma as well. So I think it is important not to try to jump to a diagnosis. One clue which you can get whether a lesion is benign or not is whether you have a sclerotic border. So if you go back to your first X-ray, the first set of slides, where you showed, almost all of them have a sclerotic border. The one before this. So if you look here, many of these have a sclerotic border, maybe except the one with the hemangiopericytoma. And that itself is rare for a giant cell tumor. Most of the giant cell tumors will not give the bone enough time to form that sclerotic rim unless, yes, there are some of them, there are rare ones which will have a sclerotic rim, but most of them will not have. And sclerotic rim also tells you that this is more likely to be a low grade or a benign tumor. So that's one clue you can get from X-rays. The other clue you can get is whether there is a complete rim of subperiosteal bone on the soft tissue component. If you look at the first one, an ABC, where you can see a nice periosteal rim, that tells you it's benign. It doesn't tell you it's GCT or not, but it can tell you it's benign. So if you see a solid rim, then that is something which tells you that this is something benign, which you can see in a few of these tumors.
Yes. Of these X-rays.
That's again not an extremely reliable sign because it just tells you that it's not something which is growing very rapidly, that it has caused a bursting out of the tumor from its confines. That's all what that tells you. And I think your message is absolutely apt, that do not assume anything is a GCT unless you have a biopsy proven diagnosis. And don't definitely jump into surgery unless and until you have a confirmed diagnosis, otherwise you're asking for disaster.
Thank you, sir. Very well said. Okay, so let's move on to this case. This is a 35-year-old female. She has pain in the lower back, and now she has started experiencing hesitancy in micturition. She has perianal radicular pain also, and this is the X-ray that she came to us with, and there was this lytic lesion in the sacrum. She also came with this set of CT scan images, wherein you can see that the upper and middle sacral segments have got lytic expansile lesion in them. So this is the X-ray and CT scan with which the patient came. We made the examination. What next? What would be the next course of action here? Dr. Gadegone, if that patient has come to you, what will you do? Dr. Gadegone, are you there?
Hello.
He has muted himself probably.
Yeah. Hello.
Now,
yes, Dr. Gadegone, yes.
Is there any neurological deficit to this patient?
This patient has started experiencing hesitancy of micturition. There is no neurological deficit.
But she must be developing the cardiac vena syndrome like a physician.
Yes.
And now it is in such a place where the diagnosis, it is confirmed as a giant cell tumor. Is it a confirmed diagnosis?
No. This is the time when patient has come to you.
Yes, I will take a biopsy. And then decide what is this.
Okay. Before biopsy, would you want to do something?
We can take MRI picture also.
Yes.
Okay. Dr. Pandit, any blood investigations you would want in this particular case?
Other investigation, skeletal, is there it can be a primary or secondary also. So that you must rule out the skeletal service would be done. Chest X-ray and all other things.
So any blood workup would you want to do?
We can do. We have to do it. Because if there is a hemolytic problem or something like that, then it will bearing on the treatment as well as it helps in the diagnosis also.
Okay. Pandit sir, would you want to do any blood investigations before going for biopsy, or you will also?
No, he has already, Dr. Gadegone has already said
Hmm.
the investigations he specifically wants, except that
Okay.
we can go for alkaline phosphatase and all those
Alkaline
things.
phosphate. Right. So Srinivas?
Yeah, agree. Alkaline phosphatase, bleeding profile.
Okay. Fine.
Normal.
So what happened? This patient underwent an open biopsy by a general orthopedic surgeon, and this is the report of the open biopsy, which shows that this is a giant cell reparative granuloma. So Chetan, this is the report which the patient has come to you with. What is your take from this? He has not said this is a giant cell tumor. What he said is
Right. So this doesn't mean it is a giant cell tumor. You have to first rule out a metabolic bone disease in any patient of a suspected, giant cell tumor. So first thing is, even before you do the biopsy, you should do a calcium phosphorus
Can you speak
alkaline.
little louder, or
Chetan, be louder. Yeah.
Can you hear me?
Yes.
Is that better?
Yes.
Yeah. So basically, this giant cell reparative granuloma doesn't mean it is a GCT of the bone. Primarily, any patient with suspected giant cell tumor of bone, you should always rule out metabolic bone disease. It could be a brown tumor in the bone, which will histologically look like giant cell tumor, radiologically appear like giant cell tumor, and the way to rule it out is a very simple routine blood investigation. Do serum calcium, phosphorus, alkaline phosphorus levels. If the calcium levels are very high, alkaline phosphorus levels are very high, then you should certainly also do parathormone levels and see whether the PTH level is very high. If it is that high, then you probably don't even need to do a biopsy in this case, because the diagnosis is very, very clear to you.
Yes. So this is exactly because giant cell reparative granuloma is when histologically your pathologist tells you that this is giant cell reparative granuloma, the first thing which will come to your mind is that this is probably a brown tumor. And what you do next is do a calcium, phosphorus, alkaline phosphatase and parathyroid hormone levels. If they are high, this much high, then the next step would be to go for a sonography of neck, or maybe an MRI of neck. And in this case, the MRI was done, which showed that there was a parathyroid adenoma here, and all she needed was removal of that parathyroid adenoma. Oh, okay. So before that, Dr. Gadegone said, we did a skeletal survey, and she had this washed out skeleton. She had these punched out lesions in the skull. Then this surgery was done. The parathyroid adenoma was taken out, and this is how the lesion healed on its own. So basically, the idea of putting this case here is that any lytic lesion of bone, even before you do the biopsy, it is wise to get the metabolic investigations done, as simple as alkaline phosphatase, which is a very cheap investigation, and probably it's a part of your preoperative major blood profile. So that will give you a hint to whether you are looking at a brown tumor or a real giant cell tumor. So Dr. Agarwal, what is your practice? I mean, do you get these investigations done before biopsy in every case, or you go for biopsy irrespective?
You have to get the investigations done. In fact, whenever you're suspecting any benign tumor, it's a standard rule that you must get your serum calcium at least, and a serum alkaline phosphatase as a screening method. Because very often you will find that this is a metabolic condition, and you can be saved from doing something major. For example, here that an open biopsy was not required at all.
Yes, I mean, this patient actually bled so much that she had to be transfused 3 units of blood.
So that's exactly what I was going to say, is that you will fall into a pit which has been dug for you if you don't look out for your steps. So it's a landmine waiting to explode in your face. So very important is that we must follow the rules, and the whole idea of doing these webinars is that you must follow the rules, because these will come more often than not. And also remember that I always look at who's the pathologist who has reported my case. I don't take the report from just anybody. Whether it's a radiologist or whether it's a pathologist, I need to know what is the experience of that person in giving such a report. Because even very experienced pathologists find it very difficult to differentiate between a giant cell reparative granuloma and a giant cell tumor. So the moment they tell me that this is a giant cell lesion, I think the diagnosis is something which I have to make, and if they are not sure about it, then we need to do the workup and then do it. But biopsy can never be the first thing in trying to make a diagnosis. That's the most important thing, as we said. That anything benign, anytime you're suspecting a GCT, please always do, if not a PTH level, at least a serum calcium and a serum alkaline phosphatase, because they're very good screening methods to tell you whether this patient could be having a metabolic disorder.
Thank you, sir. Okay, so let's move to next case. This is a 38-year-old female, pain in the knee for 6 months, gradually increasing, sudden onset of swelling and difficulty in walking. And this is how the X-ray, with this X-ray she present to us. Now there is a nice lytic lesion in the distal femur with a sclerotic margin here. Jamin.
Yes, sir.
Considering this X-ray, what will you do? You will do a biopsy. You want something more? I mean, for this patient, the alkaline phosphatase and PTH were normal, and this is how the patient has come to you. You will go for a biopsy or something in that.
So radiological investigation, MRI. I would like to do an MRI to know what is the matrix and what is exactly the lesion is there in the bone. So I think I will go for an MRI first.
So Jamie, what do you think from X-ray? What do you think this is? From X-ray, what do you think this is?
So from X-ray, I can tell that's a lytic sclerotic lesion in the lower end of the femur with a faint periosteal reaction. I can appreciate on the lateral part, which is a sclerotic type of periosteal reaction. So it might be a aggressive lesion.
Okay. So yeah, we got an MRI done. Ashish, you see this MRI and are you thinking on any different lines, or you still think this is giant cell tumor? Ashish?
Thanks, Mandi, for asking the question. As we have discussed earlier as well, as Dr. Agarwal said and everybody said in the panel, that giant cell tumors are differentials of many other malignant and benign tumors. Irrespective of how the imaging looks, we need to do a biopsy to prove it. Having said that, if you ask me this case particularly, then this looks a bit more aggressive. There is the cortex was so I was actually surprised by seeing the there was hardly any expansion of the bone. If you see on the MRI on T1 on T2 and the contrast images, the cortex looks pretty intact, but there is infiltration of disease through the cortex, and there's a soft tissue component as well. If you see at the upper end of the lesion, there may be some sort of extra bone formation. I am not sure of at present with these limited cuts, but I will be very worried. I won't straightforward call it as giant cell tumor, and I think the imaging looks pretty aggressive at present.
Yeah. So you think this is malignancy? That's what you think?
Yeah, it can be.
Yeah. So this was reported actually by a pathologist, by a radiologist as a query GCT, and but fortunately, we did a biopsy and it was documented that this is a high-grade osteosarcoma. So, Srinivas, many times patient comes to you with a MRI report which says that the differential is giant cell tumor or ABC. They're not even mentioning malignancy as one of the differentials. So in those cases also, you would go for a biopsy, or in those cases you would go for a direct treatment?
I don't think I will take the MRI reports very seriously, because ultimately the diagnosis is attained by getting a histopathological diagnosis. In a lesion like this, which is very aggressive, biopsy is a must.
Biopsy is a must.
Yeah.
So Agarwal sir, so many times, and I'm sure you have a series of hundreds of cases where the MRI guy has reported that as benign or infection or non-malignant, and then people have believed those reports, done something oncologically unsound, and then patient presents to us. So what is your message on these kind of situations?
Well, prevention is better than cure, just like in COVID.
Yes.
So it's if you know the rules, it's like saying that what would you do if you've jumped the red light and the cop catches you and fines you? It's something which is going to happen. If you break the rules, then you have to be ready for facing the consequences. So the best thing is to follow the rules. And if somebody follows the rules, then I can tell you that 99.9% of the time they will not get into trouble. And although it may mean an extra step or making a little extra effort towards getting a diagnosis, but you will not fall into a pit, as we said. So I think it's very, very clear that we should not assume anything, as you showed from your x-rays. We must get the blood test done. We must look at who's reporting, either it's a radiologist or a pathologist. We must see what's their experience and believe that report only if they've had enough experience on these cases, because as we have seen, it's very, very easy to make a mistake. And even after 2 decades, I don't think I'm very certain when I look at an x-ray whether this is benign or malignant. I think I wait till the pathology report comes. Patients will often ask us, Doctor Saab, aapko kya lagta hai? What do you think it is? Tell us, because they are worried about it. And I don't think we do anything about what it is till we have a diagnosis. That's very important, because otherwise, again, it's a ground for getting into trouble with the patient.
Thank you, sir. So there are some cases here. This was assumed to be a giant cell tumor. It looked like a GCT. It was assumed to be a GCT. Curettage and bone grafting was done without a prior biopsy. And it was actually an osteosarcoma. And this is how the patient had presented to the orthopedic oncologist. Similarly, this was thought to be a GCT. Curettage and bone grafting was done. This was actually a high-grade synovial sarcoma of bone. And this is how the patient presented, with probably an implantation sarcoma from the bone grafting side, because this patient, maybe the surgeon had used the same instrument to harvest the bone graft, the same instrument as he used for curettage. So histopathological documentation of diagnosis is mandatory for every case of suspected GCT prior to final surgery. So this is very important. So before we start discussing the curettage part, I will want or request Jaimin to tell us about what is the radiological classification of GCT, the Campanacci classification of GCT. Can you tell us what is Campanacci 1, Campanacci 2, and Campanacci 3?
Mandeep,
So
yes, sir.
there is a one input for on the previous slides from it is anonymous. Nobody has written their name.
Yes.
But maybe knowing you both, Dr. Manish Agrawal and you, words of wisdom, Dr. Manish and Mandeep. But who flows the rules? Also, why are your pathologists not doing immunochemistry for H3FA GCT and USP6 for ABC?
Agarwal sir, will you please take this?
I don't know. He has not written the name, but probably he knows the very well oncology.
Well, I can tell you that he's read the books and he's read the recent literature. But these tests like USP6 is still not available in India. So, and it's very expensive to get these translocation studies done, because you need to get these molecular studies done. They are not just simple immunohistochemistry. The other thing is that even with that, the GCT diagnosis is not certain. I think GCT is a morphological diagnosis, and a good pathologist is almost always correct when they say. One thing which I wanted to point out, which we have to be very careful about, is a giant cell rich osteosarcoma, which is often reported by an inexperienced pathologist as a giant cell tumor, because you see lots of giant cells. But it is very important to remember that the neoplastic component are these spindle cells, and if they are malignant, then it doesn't matter how many giant cells you see, it's not a giant cell tumor.
Right. So basically, the simple answer.
It's from Sekhar Kumta.
Okay. Hello, sir. How are you, Dr. Kumar? If I knew he is here, we could have taken him as a panelist, sir. Can we do that?
Yeah. Yes, you
if
can.
If he's attending, because this is the area of his core interest.
Yeah.
You can just send him a link or something. He can join.
Yes, but I do not have exactly his number of Singapore. I think you have. Do anybody have?
Let me just. Okay, fine. Maybe
I'll ask him to join, because I do not have number. I have a number of Samir Kumta, his brother.
Yeah. Okay.
Can somebody send me so that I can work
around it? Send you.
Okay, Ashish will send you, sir.
Okay, fine.
So let's get back. Jamin,
yes, sir.
The Campanacci grading of giant cell tumor 1, 2, and 3.
So basically, from the left of the screen, Campanacci grade 1 is a lesion where there is a lesion inside the bone. There is no ballooning of the cortex. It's a purely intraosseous lesion, and there is no expansion or ballooning of the bone. So that is Campanacci grade 1. In Campanacci grade 2, the lesion is still intraosseous, but as you can see, there is ballooning or expansion of the cortex. So that is Campanacci grade 2. And in Campanacci grade 3, there is a break in the cortex and you have an extraosseous mass. So that is Campanacci grade 3.
So Ashish, Chetan, maybe Ashish is busy. Chetan, what does this mean? I mean, Campanacci 1, 2, and 3. does it mean that the biological aggressiveness of the lesion is more, or it is something else?
See, whether it is biologically aggressive or not, we really don't know. In fact, GCT is not classified according to biological aggressiveness. There is no such classification. It is
Right.
assumed to be a single diagnosis. It is just that, this disease has sort of progressed more in that particular anatomical location, and therefore it poses a more complex challenge for your surgical management. So it has no histological, correlation to the radiological appearance.
Right. So is it, I mean, let me reframe the question. Is it just that you caught this patient late in the natural history,
Yes,
or
yes, yes.
the
That is
tumor which is more aggressive?
no. That is what it is more likely that we have caught it a bit late in its natural history,
Correct.
rather
Right.
than the tumor itself behaving more aggressively. Although of course we certainly see the lesions presenting very differently in different patients, and that is something we really cannot explain. Whether the patients are unable to respond to this disease, their natural way of responding to the aggressive nature of the disease, whether that is limiting and therefore you get sclerotic rims in some cases, and in some cases you don't see, in some you see a large soft tissue mass, in others you don't. So that is unexplained.
All right. So I mean, if you catch this patient, would you do a curettage? And if the patient comes here, you would do resection. It's not like that. Basically,
No, not like that.
yes,
Not like that.
yes, yes.
Not
So
like
if
that. That again doesn't define what you're going to do for it. Except
right,
that those which have a larger soft tissue mass will be definitely more challenging for you to
challenging.
do your
Yes,
surgery. But what you do is not defined by just this grade.
right. So this is for the knowledge of viewers that Campanacci 1, 2, and 3, the giant cell tumor is defined as an aggressive, benign but aggressive lesion. Campanacci 1 doesn't mean it is less aggressive, and Campanacci 3 doesn't mean it is more aggressive. It is just that the Campanacci 1 patient has come to you early, maybe just 1 month after the start of the treatment symptoms, and Campanacci 3 patient has come to you maybe after a year of starting of the treatment symptoms. So basically, it is where you catch the patient and not the biological aggressiveness. All right. So the second message, serum, the hematological examination is must. Radiological examination in form of dynamic contrast and MRI is must in every suspected case of GCT, and biopsy is must for all GCTs. Without these three, you should not start with the treatment. All right. So these are all young active individuals. We know that GCT is a disease of young. They are all the disease is occurring near joints, and that is why the challenge is to preserve the joint and motion. And that is why, because it is benign in nature, the management philosophy is more function preserving intralesional surgeries is preferable to morbid resection. Basically, you should try and do whatever is possible to save the joint rather than resecting the joint. So traditional treatment of GCT of bone, we have two different type of treatment for GCT. One is intralesional curettage, that we all know, that you scoop out the disease in pieces, you curate it out, and then in an attempt to save the natural joint. But when you take out disease in pieces, you are likely to leave behind microscopic disease, and that is where if you look at the conventional or traditional literature or older literature, the recurrence rates were very high in range of 30 to 50%. Vis-a-vis, if you do a wide excision, you are probably giving a patient more local control. That means you're reducing the chances of local recurrence, but you are losing a joint, and these are young patients. Even the reconstruction with a megaprosthesis or fusion has its own consequences, because these patients are going to live like any other patient, because this patient is not having a malignancy or cancer. So if you look at this older literature, the chances of local recurrence even at 2 years were so high, in range of 40 to 60%, which is clearly unexpected. If you look at recent literature, the local recurrence rates have come down to merely 6% at 5 years. And what has caused this difference or change is known as extended curettage, because we are nowadays not doing conventional curettage, but we are doing an extended curettage. Okay. So Ashish, would you tell us what is extended curettage? I mean, just we are going to discuss it at length, but just for our viewers to start, what is difference between conventional curettage and extended care.
Okay, so most of the general orthopedic surgeons who do not, who are not trained in oncology, they understand that in the intralesional curettage of a giant cell tumor or any other benign lesion, it means that we need to open a window and remove the disease out with the help of appropriate instruments like scoops or similar instruments. But if we do that, that has been the traditional way, which was done long back, maybe 3-4 decades back. And that's why when we quote the old literature, the rate of local recurrences are as high as 40 to 50%. But that's not adequate. What we need to do is we need to use some special instruments, or maybe sometimes we need to use intraoperative adjuvants so that we can sterilize our margins and do not leave the gross or microscopic disease behind. As you have seen the x-rays of giant cell tumor, there are a lot of septations there. And if we just do a blunt curettage, we will be leaving a lot of disease behind. So if you have to do a proper curettage, you need to use and the most important thing is to use a high-speed burr, revolution of about 50 to 60,000 per minute.
Yeah, so we'll come to that. So basically you want to say that you have to take out the microscopic disease from the walls.
Yeah, we need to sort of, in one sentence, if I have to say that you need to extend your margins of curettage to normal bone and not leave any microscopic disease which is embedded into the cavity wall. And how you do it, I'm sure you will explain that.
Wonderful, wonderful. So before we come to before we start the extended curettage part, let me just go through the indications which are the patients who are suitable for curettage. So most important, good, free, relatively painless range of movement at knee joint that shows that the cartilage is relatively good. On imaging, the articular cartilage is healthy and there is no pre-existent osteoarthritis. There is good cortical bone present, which will allow adequate mechanical burring, and adequate structural stability is there after curettage to support the reconstruction. That means presence of soft tissue mass or pathological fracture, or if the case is a recurrent case, is not actually the contraindication for curettage if the case matched these 4 criteria. So what are the contraindication for curettage? Cases like this, damaged articular surface or pre-existent osteoarthritis, large soft tissue component. In this case, you can't do a proper curettage because you are going to leave behind a lot of disease. There are cortical break with soft tissue component in more than one plane. Even if you do a curettage, how are you going to reconstruct this one? Or there is no cortical bone to support the reconstruction. Or there are multiple pathological fractures. Basically, these are the contraindications to curettage because one, they will not allow you to do a proper disease clearance, and second, the reconstruction is going to be extremely challenging and difficult. Patient will not have either good oncological or functional outcome. These cases where, if the GCT has arisen in this one of these expandable bones like proximal end of ulna, proximal radius, distal ulna, proximal fibula, distal, proximal radius, distal ulna, or clavicle or sternum, in those cases, you can certainly remove it, do an resection, and because these are not morbid resections. So what is extended curettage is this: you make a big window, you give a 360-degree vision, use variety of scoop, and then you use adjuvants. Adjuvants can be mechanical adjuvants like high-speed burr or pulse lavage, or chemical like phenol, alcohol, hydrogen peroxide, or cement, methyl methacrylate, or thermal like electrocautery, argon beam laser, argon laser beam, liquid nitrogen, that is cryotherapy, or bone cement. So we have plethora of adjuvants available, and there are a lot of controversies regarding what is must and what is not must. So I will ask first, I will start with Ashish again. Ashish, what is your methodology of which adjuvants you use at Tata Memorial Hospital and which you don't use?
Okay. So Mandeep, I would like to, change this terminology. Last webinar also we discussed this. I think this terminology adjuvants we have not defined it. What exactly we mean by adjuvant? If you ask me, high-speed burr and pulse lavage, it's not adjuvant. In today's era, it is a standard of care. So I will not call it as adjuvant. And I would like to give this message. If you not have appropriate instruments, if you do not have appropriate adequate infrastructure, and I think we should not be operating these cases. So I don't think so. This is adjuvant. This is a must, which has to be there.
So high-speed burr is a must.
Yeah, pulse lavage and high-speed burr, I think, are two things which must be there. Because
and if that burr, if you use a burr, what should be the minimum RPM? And many surgeons have seen they use the simple dental burr on the simple drill.
Yeah, so there's a great difference between the two. If you look at drill, it's got high torque, but speed is very less. Okay, right. But you need a high-speed burr which has revolution of more than 50 to 50,000 at least. It should have. Because you need to burr that bone adequately. If you have high torque, you will be burning the bone rather than burring the bone. So, having the right kind of instruments is very, very important. A lot of people give less importance to pulse lavage, but I think anybody who's doing GCT regularly will understand that how important it is to clean the cavity after a high-speed burr. How important it is to have the clear vision to detect small amount of the disease. And there may be a few places where you cannot remove the disease, and then pulse lavage helps you to disengage or dislodge those disease cells. So I think these are two extremely important. And then there's a debate about using
in TMH. Which one you use? Do you use chemicals or you use any thermals like electrocautery or argon beam or something?
Okay, so till 2006 or 7, I think we used to use alcohol and phenol, and that time Dr. Agrawal was also there. But I think from 2008 onwards, we have not been using alcohol and phenol in Tata Memorial Hospital. We do not have published data, but we looked at data internally, and though it's not case matched, but we found that using a combination of alcohol and phenol intraoperatively has not decreased the rate of local recurrences. And I am just again saying I'm talking only about alcohol and phenol. I'm not talking about liquid nitrogen, and I'm not talking about argon and cryotherapy. So this is about alcohol and phenol, and I think past 12 years I have not used alcohol and phenol during intralesional curetages. I think our results are pretty okay.
So you don't even use electrocautery. All you use is just high-speed burring. That's it. And hydrogen peroxide and pulse lavage. That's all you use.
So the answer is not that straight, frankly speaking. There are cases, so, the data which has come from Western countries, the case selection of Western world and what we do is completely different. If you will see, I think 30 to 40% of the cases which we have salvaged, they will not even attempt to salvage and they will resect. So if you have a case where you do not, you have to do sort of like excision and curettage, and you just have a periosteum exposed, and where you are not confident that burr will even act to clear that, in those areas, sometimes I use electrocautery or maybe argon beam if it is available. We have one argon beam, but we run multiple theaters, so it may not be available all the time. So sometimes I use it, but those numbers are pretty less.
Okay.
But apart from that, hydrogen peroxide is standard again. I mean, that is one adjuvant which I always use. And again, it has advantage of giving you hyperthermic reaction to sterilize your margin, and plus to remove the blood to have better vision in the cavity. So these are my views on adjuvants.
Okay. Dr. Kapoor.
Yes, dear.
In what is your practice? What adjuvants you have used in your practice?
Dear sir, I've been, I will differ a little from Ashish. I have gone through the literature, and there are definite papers to say that phenol is helpful. And it is an economical thing. I've been working mostly in government hospitals. There's no doubt about this thing that extended curettage with the high-speed burr and pulse lavage are a must. Hydrogen peroxide is easily available. I use it day in and day out. Phenol and ethanol, I give the benefit of doubt to the patient. There is no harm in not using it. That's what I mean. Economically available. That's what I mean. I do not have any personal literature, but there are definitely papers in the literature. In general, there are on both sides. Who say that the phenol is helpful, who say that the phenol is not helpful.
Right. I'll come to that. I have included some papers. And Dr. Alok Agarwal, what is your take on the use of adjuvants here? What adjuvants you have been using?
We do both. We use phenol, a very dilute solution. You just push it and do a lavage and keep on washing it out, keeping the margin safe. And then we do second lavage with hydrogen peroxide too, to take away all the burnt out tissues. But that is what we are using. And none of my patients develop any secondary carcinoma, which was one of the complications mentioned of phenol.
So Chetan, Dr. Kapoor just said that he gives benefit of doubt of using phenol to patient because it's a harmless type of chemical. So you don't use phenol. So you have a lot of erosions in using phenol. So would you just tell us why you don't use phenol?
See, one thing is, of course, there is a lot of literature which says that phenol may not add too much advantage if you are doing a good amount of burying and all those things. But primarily, I found, the concentrated phenol that we get can be hazardous if it touches the normal skin. Sometimes it can spill. It can be hazardous to the people in the OT also who are handling the material which you have used to use the phenol with. And moreover, phenol is supposed to be neurotoxic. The other thing is the body doesn't have any way to metabolize phenol, and it may remain in the body for a very long time, maybe for the rest of the life, and it could be, for all we know, carcinogenic. I mean, there is no real evidence that I can quote, but it is certainly a concern. And when we can do without it, I think I'm quite okay, not using phenol, although I used to use it till about 10 years ago.
Okay.
Dr. Mandip, Dr. Mandip,
yes.
there is a question. Dr. Mukhi is asking.
Yes.
Some of the part of the question you already answered.
Sir, yes, you asked the question. Yes.
Yeah. For how long do we use the phenol, and can the formalin be used, and how much pulse lavage? How many liters?
Sir, I will come to that in the half of the presentation. I am answering all those questions. I will just take why I am asking everyone is that just to show viewers that there is so much of discrepancy in everybody's methodology. So I will finally ask Dr. Manish Agarwal what adjuvants he used and what is the logic or science behind it, and why not use something, why use something. Agarwal sir.
Well, you know that we started using phenol. Yes. And then we started reading about it and realized that it's a very dangerous substance. It's dangerous for your colleagues. If you inhale,
sir, can you say speak a little loudly, sir? Can you speak?
Yeah. So if you inhale phenol, you may end up causing damage to yourself, including the risk of carcinogenicity. So this is something to remember. It's also neurotoxic, and phenol does not get soluble in any liquid other than alcohol. So even after multiple washes, you don't really get phenol completely out of the body. And we haven't really done any tests to know whether we've got even a mild phenol toxicity, etc. So finally, we decided that maybe it's not worth taking the risk with phenol. I actually started using the argon cautery in order to cauterize it. And even if you don't have an argon cautery, you can use a simple cautery. The whole idea is to just do a heat cauterization or a thermal cauterization of the entire cavity, and that doesn't matter. Now, I think what is very important to understand is there are no rules that I must use this or I must not use this and I must use that. I think the final responsibility of the surgeon is that you have to clear the disease. And how you clear the disease with what weapons you have depends on you. You form your strategy and said, okay, I will use it here, I won't use it here. As long as you can get the disease clear, and you will not get a very high risk of recurrence, I think you've done a good job. So if you can do that with a burr alone, well and good, which you can do if you've got just bone. But most of our tumors have got a lot of perforations in the bone. There are soft tissue components. There is a periosteum on which it's very difficult to use the burr. So in which case then these are the areas where I think I'm a little safer if I use hydrogen peroxide, as Ashish said. There's nothing wrong with using a chemical adjuvant. Absolutely safe. We know from years of use. And I also use the argon plasma cautery if I think that's going to help me, give me that additional layer of security. Worst come worst, it will not be useful. but there's nothing wrong with using it. So I think every surgeon should decide what is the armamentarium or what are the weapons they have, and then decide finally that what am I going to do in a particular case. And the same thing applies with whether you're going to do a curettage or whether you're going to do a resection as well. The responsibility is surgeons. There are no fixed rules that this patient should get a curettage, this patient should get a resection. I think each surgeon has to decide what they are able to do best and what works in their hand, and then do that as the method.
But the high-speed burring is absolutely indispensable. That is what is.
That goes without saying. I don't think you can do GCT surgery. There is no curettage without a high-speed burr. And I agree with Ashish, and I've been saying it in all my talks as well, that I don't think that a burr is an adjuvant.
Right.
A burr is an essential part of surgery, and we have to accept that.
Thakkar sir, you're saying something?
Yeah. The question is from Dr. Praveen Kabra, that you're not mentioned the spirit can be used as adjuvant.
No, spirit cannot be used as adjuvant. I mean, it has not been described anywhere. I mean, I'm not aware of it. Ashish, are you aware of spirit being used as an adjuvant?
No, in fact, it should not be used. All spirit is actually mixed with methyl alcohol.
Yes.
So you can use pure alcohol. You can use a laboratory ethanol.
Yes.
Spirit has been mixed with methyl alcohol so that people don't drink it. That's why it's blue in color. Just to tell people that you can't drink this. There have been cases like that, and if you use spirit, you are putting that patient into danger of methyl alcohol poisoning. So you definitely will not be using spirit. Alcohol is something which can be used as an adjuvant, but it has to be pure alcohol.
Right.
So Dr. Yogesh has joined.
Yes, so Dr. Yogesh and Dr. Abhijit, I welcome both of you.
Mandeep, what is very important is, as Dr. Agarwal said, that it is the principle which is important, not the method. Okay, and there can be thousands of things which can be used. You know, people have started talking about multiple other things, but we need to see what works in our hand and what is safest for our patient. You know, I mean, you will find some case reports in the literature that I used this thing and I had no recurrence in one case or two cases. That doesn't matter. But we should here, as a part of teaching, we should talk about the standards which are available. Yes, you know, it's not that using alcohol and phenol is a crime. It definitely people use it, and if people are comfortable, they are okay. We were using it, but we did our own literature search. We found that, you know, it is not helping us enough. And we thought that we can move. And again, I will say, like Dr. Agarwal said, that he uses argon in the areas where he cannot burr, which is absolutely, you ask anybody, you want means to decrease your local recurrence. And so there is no doubt that if you have a good bony shell, high speed burr is the answer. But you get cases where there are pockets where you do not have bone, you have sieve-like periosteum.
So we'll come to that.
At those areas, some people use alcohol, phenol, some people use argon. So that these are different modalities. I think whatever we are comfortable, we need to remember the principle rather than the method.
Right. So I'll just
yes. One thing I wanted to tell about the use of alcohol. One should be extremely careful using absolute alcohol. It is you know, can catch fire. It can, you know, ignite. So using the cautery and alcohol at the same time can be a deadly combination.
Yes.
Moreover, if it catches fire, you can't even see the flame because it is very faint and blue. And, you know, if that alcohol spills on the drapes or clothes or all around, it can be a disaster on table. So one has to be extremely careful when using alcohol.
Absolutely. There won't be a part, the good part, there won't be any recurrence later on. If the limb survives.
And that may be your last surgery.
Mandeep, as Chetan said, I had one experience where I had asked for hydrogen peroxide, and there's one company where the bottles look similar for hydrogen peroxide and spirit. Okay, and they ended up giving spirit, and I just started using the cautery, and there was a fire on the table. Unfortunately, it was a very small quantity. We could salvage it, but this could be a dangerous situation.
Mandeep.
Yes, sir.
Nowadays, don't worry about alcohol. It will be used for something else. So it won't be available for surgery.
Typical example of you know. So one case was referred to me for opinion, and I think you guys might have also seen that. somebody in the southern part of India did his first case of curettage with liquid nitrogen. And the clinical picture was that everything in the proximal tibia was burnt and the bone was burnt. And when the question asked that, how did you do that? He said, I saw some doctor showing a slide in one of the conferences. What I'm trying to say is that that is not the way how we should be treating. We should be treating what works in our hand, what you are
Right.
familiar with. I think that is very important.
Mandeep, your battery is going on.
Yeah, no, I just switched on.
And the computer's battery.
All right. So I'll just take you through this nice animation which Dr. Chetan has prepared. This is a typical GCT. What you do is you make a smaller window, you take out, do the primary curettage, you extend your windows as much as you want. Yeah. Then you have 360-degree vision and good light in it. Now you can see a lot of septas here. Underneath the septas, you have a lot of tumor seeding in. You need to make it a completely unilocular cavity. You do more curettage. Once you're done with your primary curettage, your border still have microscopic disease, and to kill that microscopic disease, you use either high-speed burr. You can even use phenol taken on peanut, or you can use argon laser or electrocautery. After that, lavage, and that is where you end your extended. So the first question is how big should be the window? You know, that is always the first question. The orthopedic surgeons have seen a lot of trepidations in extending the windows. But typically, the answer is the length of the window should be as much as the extent of the lesion. When you do that, then only you can have vision, 360-degree vision, and then you can have a good clearance and reconstruction, and then you can have a good looking X-ray. Even if when you have, whenever you have this kind of a cortices which are already soft because of infiltration by disease, you don't hesitate in taking out those part of cortices and see to it that all that softened cortices have been removed. Whenever you have a Campanacci 3 disease, that doesn't mean you cannot do a curettage, because what you can do is you can take out the entire soft tissue mass and block like this, and then all the softened part or ballooned out cortex has been removed, and the residual bone is pretty strong enough to do a proper curettage. So length of the window should be big enough to expose complete supra-inferior extent of disease to give 360-degree vision to the surgeon. Ballooned out cortex can be removed along with window if it does not risk intraoperative pathological fracture, but softened cartilage must be preserved, and you should rely on adjuvants for disease clearance. Use of high-speed burr. We had a lot of discussion on whether, as Dr. Ashish and Dr. Agarwal had said, that high-speed burr is no more adjuvant, it is an integral part of the curettage. So this is typically a pre-burring cavity, when general orthopedic surgeon would think, okay, this is nice bleeding bone, I should start reconstructing. But when you actually do a burring, this is how the burring is. As you can see, the burring will really, you can see that now that red part of the cortex is gone, and what you see underneath is a ivory white cortex, and this is where how post-burring cavity will start looking. This is a nice paper which had compared the patients where only burr was used as an adjuvant, and burr plus other adjuvants were used, and local recurrence rates were absolutely similar. So they concluded that if you do a proper burring, you may not add any further adjuvants. This is
interesting. I'll tell you something interesting is that we initially took the burrings. I mean, after we have cleaned the curettage, like you said, the cavity looks good. Then we burred and we sent that for pathology. And in almost every case, they could demonstrate tumor in it.
Tumor, that's true. I remember that, sir. I remember that, yeah.
Mandeep, Dr. Mandeep.
Yes, sir.
There again a comment from, yeah.
Hello. Yes, sir.
Yes. Again a comment from Dr. Sekhar Kumta, probably.
Yes.
I'm not able to connect him, whatever be the problem. Just I'm communicating to him. Please send me the email ID so that I can send you this ID of the meeting so he can join us.
Okay, sir.
So his comment is phenol is a fixative and is an excellent adjuvant. It should not be used as a free liquid. Use a phenol sock gauze to pack the cavity, but it is toxic.
Yes,
What is his comment?
I'm coming to that, sir. I will show the method how to use phenol.
Okay.
So this is a paper which compared resection versus curettage group, and they concluded when Burr is used, the local recurrence rates are almost as much as the recurrence rates of wide excision. Coming to the use of chemicals, I'm sure, as Ashish says, Dr. Agarwal also said that hydrogen peroxide is a harmless chemical, and I'm sure everybody uses it very freely. And again, it is tumoricidal in vitro. I'm sure in vivo also it is tumoricidal, and but it has never been investigated as an isolated adjuvant, and that is why we don't have data whether to use hydrogen peroxide. It is giving us any advantage or not. Coming to phenol and alcohol, as Dr. Kapoor mentioned, we have literature on both the sides. This is a paper which says that adding phenol does not improve any local control. This is similar conclusion from another author that adding phenol and alcohol does not give you any advantage if you have done a proper mechanical burring of the cavity. Vis-a-vis, if you look at this paper, it says phenolization is an effective and safe local adjuvant therapy for GCT, and they did not find any problem in using it. They did not find any complications with use of phenol, and as they also concluded that they are using phenol in every case of theirs. This is another paper which said that the use of phenol reduced the recurrence rates to only 6%, and that is why they said besides polymethyl methacrylate, using phenol is also helpful. So basically, we have a lot of conflicting literature on use of phenol and alcohol, and it is absolutely surgeon based. But whenever you use phenol and alcohol, you have to be very, very careful, as our panelists have very clearly mentioned that this can have intraoperative disasters if you're not very careful. Now coming to the solution, percentage of the solution and contact time. So this is a nice paper which had studied 6% versus 70% versus 80% concentration phenol. And what they have said is only 6% is enough, and your contact time should be minimum 3 minutes. So that's all you need. Using higher percentages of phenol is more toxic because phenol in a small quantity can be excreted by the kidneys, but in larger quantities they actually get accumulated in the renal calyces and can lead to renal cell carcinoma. You can find the traces of phenol in the surrounding lymph nodes even after a year of use, and that is where phenol should be used with a really great caution. So when you have to use phenol, this is how it is usually taken, as Dr. Kumta commented. You take it on peanut and you apply it on the surface. This is done only after a proper burring has been done and the tumor has been washed out. You continuously keep sucking the droplets of the phenol because it should not come in contact with any surrounding soft tissues because it can be really toxic. Once you are done with the phenol, you have to wash it out with absolute alcohol, because absolute alcohol is not only, it neutralizes the toxic effect of phenol, but it itself is also tumoricidal. So it can also help in reducing your local recurrence. So coming to the thermal means, that is electrocautery or argon laser, I have no personal experience with using cryotherapy, so I will not talk about it. But using of electrocautery or argon laser, basically it causes coagulative necrosis of tumor tissue, and the local recurrence reported is between 0% and 12.5%. So when you have to use electrocautery, it is like this: you put it on spray mode in your coagulation cluster. There is a spray mode. You put it on spray mode. You put it on 100 power, and then gradually you spray it to all the walls. When you are using, this is the only case where I have used an argon beam laser. Dr. Agarwal is using argon beam laser very, very regularly. Sir, can you tell us what is the advantage of using argon beam over electrocauterization?
Well, number one is that the beam is directly in your control. So you can actually focus it on the area that you want to use it on. So you can use it even in the spine, for example, by keeping the dura safe.
Okay.
Since it is not electrically connected, what happens with the cautery is that you're going to pass current through the body till it gets grounded. because these are monopolar cauteries, and there is always a danger if you have a pacemaker, some cardiac arrhythmia. All those things are always possible because you're going to use a very high cautery current when you're going to cauterize. So you could use it if it is a very small area, but if you're going to extensively use it on the entire cavity, I think the argon plasma is safe. I would say that I'm lucky that it is always there in the hospital, and I've seen it was there even in Tata because it's used by the GI surgeons to control bleed from esophageal varices from the liver.
Right.
So it's always there. You just need to ask for it and you can use it. And it's extremely easy to use and pretty effective in burning the area that you want. And you also know that you can actually, the depth of that heat penetration can be controlled by how long you want the flame or how long you keep the flame in contact with that particular area. So it's very much controlled. You can decide whether you want to just have a superficial burning off or whether you want to have a deeper penetration of the heat. Unlike cryo, and that's the bigger advantage over cryo, where you can't control the depth to which the cryo is going to penetrate and then create fractures after that.
Yes. Srinivas, you want to add something, Srinivas?
Yeah, so basically with the regular cautery spray mode, it tends to burn more. It tends to burn much more and the control is much lesser. The tissue ends up with, you end up with charred tissues. Generally, I use it in areas where I can't use high-speed burr.
So yeah, that is, I'm coming to that.
Yeah.
So basically, this is what Dr. Ashish Gulia was saying and Dr. Srinivas is also saying. These are the areas where the tumor has come out of the cortex. This is the inner part of the periosteum, where you can't use your high-speed burr very effectively. And these are the areas where, using electrocautery or argon laser would certainly add to your clearance and reduce your chances of recurrence in this particular area. Ashish, you wanted to say something? Unmute yourself. Unmute yourself. Unmute yourself.
I wanted to ask Dr. Panchwag, what has been his experience regarding using electrocautery or
yes,
argon?
Yes, Ashish, Yogesh.
Yeah, we haven't been using argon. We do use electrocautery whenever it's indicated, but definitely not in all cases. And though we have not used electrocautery in all our cases, we don't find any difference in the recurrence rates, basically. We haven't yet analyzed our cases as to when we have used the electrocautery versus when we haven't used. We'll have to look at that particular literature.
Okay, thank you. So this is a small video of curettage. Overall, this is most important. Before you make the window, you have to the surroundings have to be covered in hydrogen peroxide soaked bath species, because any spillage you want to contain. Most of these GCTs have damaged the cortices to an extent that you can just take it out with the help of a simple scissor. Then you use a larger instrument like spoon to take out the gross disease so that the spillage is little less. Yeah, and this is where you start using your curates. Variety of curates are used, and this is how you keep doing the curettage. And the hydrogen peroxide. This is where most orthopedic surgeons will start reconstructing. This is where the extended curettage will start. This is the high-speed burr, where you can see with the help of burr, you can really take out that microscopic disease which is stuck on the surface of the cavity.
Mandip, 1 second.
Yes, sir.
Hello.
Mandip, yes, sir. Yes, sir.
Please go back a little bit and show that a ridge inside that cavity.
Oh, sorry.
And we say specifically that ridge has to be removed by burr. You can, when very nicely seen in your, yes, after that a ridge is very nicely seen just opposite the, just once it has been over.
Yeah.
Very nicely seen.
So this one.
Yes. Yeah. So all those ridges, all those ridges have to be, it is very nicely seen in your, right?
Yes.
And
so
it has to be made into a single cavity rather than.
Correct. So
Mandip, there is the input again from Dr. Sekhar Kumta is.
Yes, sir.
We found the use of arthroscope camera help us to identify the hidden septae and tumor crypts. It is very simple addition to the armamentarium.
Yeah, that's a
and probably now he is having a problem with the bandwidth compromise. So he said, sorry, I may not be able to comment probably.
Okay. Thank you, sir.
I have asked him to join, but he's not sending me the email ID. Once he sets the email ID, the mobile number is not working. That is not problem, WhatsApp number. Yeah.
No problem, sir. No problem, sir. So this is how the electrocautery has been done. And then if you have to use the phenol, this is how it is taken on peanut, and then you put it in and you apply it to the all the nooks and corners, and then use an absolute alcohol and wash it out. So this is how the extended curettage is typically done, and then you can go and reconstruct your cavity with whatever means. So we have, in my practice, I have combined all these three methods. I have, again, it's an unpublished data, but the recurrence rate is around 5%. A lot of literature, we have compared the literature says the recurrence rate is between 8% and 25%. The only paper which I could find, of course, it's a small number, 23 patients, but more than 10 years follow-up. They have used all three: electrocautery, burr, phenol irrigation, and cementation, and they have found 0 recurrence rates at 10 years in their paper. So third take-home message: adequate exposure, high-speed burring are indispensable ingredients of optimum curettage. Use of chemical and thermal means may not improve local control in properly burred cavity. Use of phenol or cryotherapy needs expertise and experience, can lead to interrupt disasters if taken casually. So I can see Abhijit is also there. Abhijit, at GCRI, what are your adjuvants that you use? We know that you are doing a lot of numbers in giant cell tumor. So what adjuvants are you using?
So we are using hydrogen peroxide, burr, and electrocautery. In very few cases, we have used argon beam laser. Less than 5 we have used.
Okay.
So most commonly we are using only 3.
Yeah, fine. So once you are done with your curettage, you are left with a large cavity like this, and you need to.
One word of caution for
people
who are using phenol. You have to be very careful about using hydrogen peroxide after you have used phenol, because it's going to splash as bubbles and you can get burns. Especially eyes, etc. You have to protect when you're using hydrogen peroxide after you have used phenol. So that
yes. No, it is a dangerous substance, and you have to use it very carefully, sir.
And the second thing is, you ask how big the window should be, and I always say it's not a window. You don't enter a house through a window. You will make a door.
Very well said.
A big door. It is not a window.
Yes, sir. Yes, sir. Yes, sir. So there are 3 options of reconstruction. You can use bone grafts, you can use bone cement, or you can use combination of the 2. So I'll just run through this 4 slides. What are the advantages and disadvantages of cement and bone graft? So cement advantages: it is readily available, it is cheap, quantity is not limited, there is no donor site morbidity, immediate weight bearing and function in majority of patients, and exothermic reaction and exothermic and chemical properties will reduce the recurrence rates. But it is non-biological, so it could have future consequences. Exothermic reaction could damage cartilage, plates and implants are more frequently you need to use, and it increases the perioperative complications rates as evident by some literature. If you talk about bone, it is biological, so once incorporated, it is permanent. These are young patients, you can even allow them to indulge in sports. It does not threaten the health of the cartilage, and implants are needed less frequently as compared to cement. But its quantity is limited. There are no bone banks in majority of the areas, so allografts are not available, and even they are not without the issues. There is a lot of donor site morbidity, immediate weight bearing and function is not possible, almost 6 months of rehabilitation is needed, and that is where stiffness and weakness is pretty common. So how to decide what to use? I will want Dr. Yogesh Panchwag, Dr. Ashish Gulia, and Dr. Manish Agarwal's view on this, and then I will ask other panelists. Yogesh, how do you typically decide what material to use?
Well, basically, I would like to divide that into the patient-related factors and the disease-related factors as well. Patient-related factors would be something like how early the patient has to go back to his schedule, whether he's willing to sort of go for a second surgery to harvest the iliac crest autografts in cases where the allograft might not be available as one of the options for bone graft reconstruction. The disease-related factors would be how big is the cavity and what needs to be, whether it's really going to be filled with autografts, whether you have an access for allografts again, and things like that. Of course, we'll have to counsel the patient. Well, there has been a paper from Joe Benevenu from the New Jersey Center where they have stated that the non-oncological complications are much lesser when you use a subchondral bone graft, and the rest of the cavity can be filled up with bone cement. And there have been other non-oncologically related complications associated with the use of only bone cement for reconstruction in the later stages, and notably being fractures, early onset osteoarthritis, and cartilage damage. Though it has not been conclusively proven that it does happen because of the exothermic reaction of the cement. Most of the papers have used cement as an adjuvant modality, that the exothermic reaction does help in sort of controlling the local recurrence rate, and the monomer being cytotoxic for the stromal cells of giant cell tumors. So that is more often referred to as an adjuvant modality. But these are the particular factors that we look at when we decide whether to use bone graft or bone cement for reconstruction. Typically, we might end up using a combination of both.
So, fine. So, Ashish, how do you what to use? Ashish, are you there?
Yeah, Mandip. Hello.
Yes, Ashish, we can hear you.
Yeah. So I think as Yogesh rightly said, that it is every case is different, and there are multiple factors which we need to consider. Patient's age, what type of cavity you have to curate. I think that's very important. The amount of subchondral bone which is left is very important. And as I have earlier said, and Agarwal sir also said, see, it is very important to follow the principles rather than to fix on one particular type of technique. The principle is that you need to have a congruent joint. You need to reconstruct the cavity in a way that it is as normal as the other anatomy. Now, there are various means, and each has its own advantage and disadvantage, and I think we have discussed them a number of times. But what principle we need to follow, that we need to reconstruct the cavity in a way that we can maintain the congruity of the joint. As Yogesh also mentioned, there is meta-analysis and systemic review, and the Mayo Clinic paper, which is showing that using cement can decrease the chances of local recurrence in these patients. So it is becoming more popular, and obviously advantages of not giving morbidity to patients, especially if your patient is an elderly patient and you can still salvage the joint. So you need to sort of solve it as a jigsaw puzzle. You have few factors in mind. You look at age, you look at the type of cavity after curettage, what is left to reconstruct. You look at what is available to you. Now, we have been using allografts a lot, but it is not available to everyone. And, you don't give much morbid to the patient, and you can have quite nice allografts. We have used combination of allografts and autografts. So there are different modalities, but cement is getting more and more popular.
So
because
you are saying that for you, most important thing is to maintain the articular congruity.
Yes.
Giving a subchondral thickness of bone. That is what is more important according to you.
Yes.
Right. Agarwal sir, how do you decide what will you use, whether you will do cementation or a sandwich or simple bone graft or deconstruct? What will you do? How do you decide today?
Well, after using each and every method in circles, I think now we are quite clear on certain things. At least I know what not to do. I don't know what exactly is the best option, but we know what not to do. A clear what not to do is to think that cement will take care of an inadequate curettage. I don't think you're going to let cement be an adjuvant. Cement is only a filler. So if I'm going to use heat, I will use argon and heat the cavity and not depend on the heat of the cement. So that's one factor which is important. Second is, if I have a cartilage which is pliable, in the sense is I can deform that cartilage with a finger, and it is like a ping pong cartilage, I'm not going to use cement on that cartilage directly. I need to give some kind of a bony support to that friable, thin cartilage. Otherwise, that cement can actually make a hole through the cartilage. And we've seen a couple of cases on that. These never get reported in literature. So the literature always says that you can safely do cementing. And we have to remember that all the cases are not the same. Each and every giant cell tumor has got a different geography. It's got a different layer, different place where the cartilage is thin. So finally, you have to use your judgment. I normally try to press the subchondral bone with my finger and see that if I can deform it. If I can deform it, then I need to add a layer of subchondral bone. If I can't deform it and I want to use cement, then it's okay to use cement on that. So if I want to still use cement, I don't have allograft bone, I'll use a little bit of bone, build up the subchondral area, and then go and add the cement on.
So yeah,
and
so see,
remember with cement is that it is only good for weight bearing in compression. I'm not going to depend on that cement in torque. So if I have a great big volume, which is occupying more than 75% of the circumference or the volume of the condyle, then it is risky to use just cement, because you can, just like you get a periprosthetic fracture, you can end up with peri-cement fractures when there is torsion.
Yeah, thank you. So viewers, as you can see, all these stalwarts have difference of opinion here as to how to reconstruct the cavity. I think it is again the surgeon-centric decision, but there have been certain areas where we have some consensus, and we'll come to that. Let us take some few. Let us take a few.
Can I interrupt?
Yes, sir.
I just one thought occurred to my mind.
Yes.
Let us ask this question: if you have the facility of bone bank where the bone is easily available, will you still use cement?
Ashish has availability of bone bank, so he can actually.
If the free supply of bone bank at your hospital center, would you like to use cement?
Ashish.
Okay. Yes, sir. I think every case is not same, and it will depend upon case to case. If I have an elderly gentleman and I want to ambulate him early, I don't have enough support on the cartilage. I mean, I'm absolutely okay in using cement. But there are many cases where we have used allograft studs, but I think every case is not suitable for one answer. We have to evaluate each case differently and then take a call.
So, can I just,
yes, sir.
Can I make a small comment?
Yes, sir.
My impression is, I have not been using studs. The bone graft has to be mosselized and the cavity has to be packed fully. So much so that it is with the thumb. Ultimately, once you finish with the thumb pressure, there is no place left to fill more cement for more graft. What is my impression is that once, if you have available good quality of bone, where quantity is not the concern, where you are not taking from the patient's body, a biological thing remains the best thing.
Right.
This is my impression.
Yeah.
Only thing is the cement is that it is easily available, economical for a general person. It is good.
Right.
But if we have a biological reconstruction which can be done easily by everybody, I'm talking of availability, then probably it will be better.
Yes, sir. Thank you.
Mandeep, there is a question from the audience about the sandwich technique.
Yes, sir. I'm coming to that.
Going to come there.
We are coming to that, sir. So now, Dr. Kapoor, thanks for your comment. Now, I think, as I said, there is a little consensus about how to reconstruct a cavity vis-a-vis the type of the cartilage that we are left with. There are cases when after curettage, you have a nice thick subchondral bone and cartilage available, which is type A cartilage, or you have thin subchondral bone, but the cartilage is still strong. It is not deformable. As Dr. Agarwal said, with your thumb, you can't deform it. That is type B cartilage. And then there is type C cartilage, where there is practically no subchondral bone left, and this cartilage is soft, ping pong ball like, and deformable. Now let us see the cases one by one. So this is a case, Chetan. This is a type A cartilage, and this is a 19-year-old young girl. How are you going to reconstruct this?
After 1 second, let me just come on now. Yes, 19-year-old girl.
Yes.
With
nice thick subchondral bone.
Right. Here, we can use either of the two options. You can either use bone graft if the cavity is, small enough for that, you get enough graft to pack it with, or you can use cement. But important thing is you will have to use an implant to basically reinforce the bone. Otherwise, there is a risk of supracondylar fractures in these.
That's right.
So distal femur, I would always use an implant.
Okay. Yogesh, one sentence. How will you reconstruct this one?
Well, I'll be probably using either allograft if I have got some left, or then I'll be using cement with internal fixation.
Ashish, one sentence. This patient.
I missed the age, sorry, age.
19.
As far as possible, I will use allograft struts and fixation.
Okay. Jamin? Jamin, are you there? No. Abhijit?
No, he's not there.
Abhijit?
So we'll use cement and plate for this case.
Okay. Agarwal, sir?
Well, first thing is I will differ in opinion from what Dr. Kapoor said. I don't think you need to fill the cavity. That's one rule that we've learned. We've started using struts, and we know that all you need to do is to prevent that cavity from collapsing. Now, if you fill the cavity, the biggest advantage is that if there is a recurrence, you will see the void quickly. And that's the reason why cement is also useful. But if you fill it completely with morselized graft, then again you get that advantage. But remember that the amount of allograft related problems come with the volume of allograft that has been used. And we've seen that if I have a big cavity and I use a large amount of allograft, I have more chances of getting problems, allograft related problems like seromas, drainage, infection, all those things will increase if I have a larger volume of graft. So I think a sandwich becomes a good option. But in a young 19-year-old, I would like to reconstruct with bone, if that is possible. And we normally would reconstruct both the subchondral side as well as the metaphyseal large.
Here the
defect.
subchondral bone is very thick, sir. I mean, it is very nice.
It looks very good. So here, then I would probably just use allograft fibular struts if I have, or any allograft struts that we have. And that would be a good reconstruction in this case. If there is any other reason that they can't wait, they are in a hurry of weight bearing, then only you would use cement in a 19-year-old. And the same, it would be exactly opposite in a 60 or a 70-year-old.
Right.
Yeah, just a quick word, Mandeep, as Agarwal sir was saying, the complication of seroma and aseptic discharge that we typically get is very common with freeze-dried radiated grafts. What we use are fresh frozen allografts. And there we have noticed in our cases that we don't face these typical problems that are related with allografts. They work wonderfully well, and we're very happy using them.
Thank you.
I'll try to agree with you, sir. I've been using defreezed. Fresh frozen minus
Yes.
80
Wonderful. So this is exactly what was done. This was a young girl, and these fibula struts were nicely press fitted inside. Dr. Pandit will remember this case because we did this together. Sir, you remember this case? And as you can see, how beautifully it is completely,
Mandeep,
so
one more input only when you have asked.
Yeah.
That, as Dr. Agarwal said, that you just have to see that the cavity does not collapse.
Yes.
See, there was one surgeon from England.
Yeah,
there was one surgeon from England. I just cannot, you may be knowing the name. He has popularized the method that just go on curettage, extended curettage, and no reconstruction. And he had shown many cases, and we had also tried.
Dr. Grimer has published that paper.
Yeah, Grimer, yeah. No, he was, the person who started was Grimer's previous one.
Okay.
I'm not getting his name.
One series from India also.
Yes, that don't reconstruct. Just let the cavity heal on its own.
One series from PGMS Rohtak.
Right.
Yeah.
Dr. Kundu has joined from the Rohtak. You can ask him.
Oh, Kundu sir, how are you? Okay.
Hello. You're not joined by the audio. You're just joined by the video only, Dr. Kundu.
Okay. So this
join with the audio also, please.
Similarly, this is another patient where the cavity is so small that we could have actually left it alone without reconstructing this. We could have just curated and done nothing, but patient wanted to go back to their normal life as soon as possible because he was a daily laborer. That is why we had put in this cement, and even at 8 years, he is doing extremely well. And the cartilage is also very nice and thick, and there is no further damage because of the cement. This was the function. So when there is a thick subchondral bone left, as all the panelists have said, the idea is not let the cavity collapse. You can just put maybe some graft, maybe strut graft. If the cavity is small, you can even fill it up with morselized cancellous graft or allograft if it is available to you. Or you could use cement, and it usually will have excellent function. Now let us look at
Srinivas here.
Yeah, Srinivas.
On the point of whether we should use internal fixation,
Yes.
Generally, all cases we should keep the plates or internal fixation
Yes, it
devices
should be
ready.
ready. Yes.
But
Yes.
the decision whether to use or not should be based on post-curettage situation. You see
Yes.
whether how
Yes.
much of cortex is available, what stability is there. Based on
Right.
that, you can take a decision whether you want to put a implant or not.
Thanks, Srinivas, for your inputs. So now this is another case. This is a 27-year-old lady, and this is how she has come to us. Now I'll again have opinion from the panelist how they will reconstruct this one. Srinivas, what will you do here?
I generally prefer a biological reconstruction. Here the cartilage, I mean, a post-curettage, I expect the cartilage to be quite thin here. So this needs some kind of a stud graft under the cartilage. I'll probably use a tricortical allograft graft, and to support that, we may use a fibula, either allograft or a autograft.
So something like a T construct, as we call it.
Yeah, preferred.
Okay, yeah. Ashish, what will you do here? Ashish? Okay.
Yeah, Mandeep, yeah. I think in this case,
is after the curettage, the cartilage was not deformable, but it is very thinned out. In this case,
I think I will end up. I mean, it's an option. You can use either cement or you can use paste. Either you can use either. But if I don't have a bone bank, I'll just put cement and a plate.
Okay, Chetan.
I will use only cement in this case.
Only cement in this one?
Yeah, no implant.
Okay, fine. Kundu sir, how are you?
Yeah, I'm fine.
Okay, Kundu
Am I audible?
Yes, now you are audible. I will take your help in coming discussion.
Okay, I'm seeing the case.
Yes, Agarwal sir, in this kind of case, what would be your method of reconstruction?
Well, I am a proponent of the sandwich method, and I would use 2 millimeters of subchondral bone,
right,
and then build it up with.
So, sir, when you say 2 millimeters of subchondral bone, you will put a mercerized graft or put a tricortical iliac crest underneath the cartilage, horizontally placed. Sir, Agarwal sir. Chetan.
Yes.
I know you. I mean, I have seen some amazing results of sandwich reconstruction in your hands. Sandwich has never been good with me. Sandwich has never worked well in my hands. But I have seen some amazing cases shown by you. So can you tell us some technical tips about sandwich construction to our viewers?
Yeah, basically in sandwich, what we do is we keep a layer of bone in the subchondral area, and then we keep an interface of a thin layer of gel foam between the rest of the cavity and the bone graft, and then the rest of the cavity is filled with bone cement. And you may use an implant at that time or not, depending on what is the location of the disease. The bone graft that I use is always autograft, and I always take iliac crest graft from the inner table, morselize it. I don't have a morselizer, so I use a nibbler. It's a bit of a tedious job, but it is possible. And then I make it into as small pieces as possible and mix it with some of the bone marrow that we get, or the blood that comes out or oozes out while you are collecting the graft. And that is something that you can actually plaster on the subchondral surface. You can just squeeze it with your hand or use a gauze to help you do that, and it will stick if it is nicely morselized. And on that you can layer a thin layer of gel foam and pack the rest of the cavity with graft. Very important thing is, when you are taking autograft, you should be very sure that you are not contaminating the bone graft harvest site, especially if you are harvesting the graft after you have done the curettage. A lot of times when I am fairly sure I am going to do a sandwich, I take the graft first and then I go to the area of curettage, so that the risk of contamination of the bone graft harvest site is totally eliminated.
Chetan, what is the rehabilitation protocol of this sandwich patient that you do?
In my sandwich cases, I am a bit guarded about weight bearing. I allow immediate range of movement, but as far as lower limb is concerned, weight bearing I allow after 3 months.
So,
and of course, before that, I do an X-ray and see how things are, and then slowly guarded, gradually I make them full weight bearing.
Dr. Agarwal, are you there, or is again?
He was there. He again some unstable internet connection. Now he's there. Yeah.
Okay.
So,
So Dr. Agarwal, hello. Agarwal,
I
sir.
don't know what is the correct method of protocol for weight bearing after a sandwich. I suspect we don't need to keep them off weight bearing for 3 months as we've been doing so far. I think after 6 weeks, you can start them on gradually increasing weight bearing. And by 3 months, I generally get them to full weight bearing if I do a sandwich.
Sir, do you use tricortical iliac crest, or you also use morselized iliac crest, as Chetan has said?
I use the tricortical strut because we've had cases where the subchondral bone has got resorbed and the cartilage has collapsed. So I don't rely on it. So I use a little bit of morselized to fill in those crevices which are left because the iliac crest does not conform to the geometry of the articular surface. But I would like to use a strut, at least a thin iliac crest strut. We use a bicortical strut so that we can leave behind one cortex of the iliac crest when we take it. We don't need a great amount of bone to do this sandwich reconstruction. And I think, like what Chetan said, I would always like to start with by taking the bone so that I don't leave any chance of contaminating the iliac crest site with the graft unless I don't know how much bone I'm going to need. Then I leave it to extract it later. But then we change the whole trolley and all the instruments are different, and we make sure that there's no cross contamination.
Wonderful. So this is exactly what was done. Underneath the cartilage, some morselized graft was put, then rest of the cavity, then a tricortical crest was put, and the rest of the cavity was filled up with cement, which is typically known as sandwich reconstruction. Now you can, this is iliac crest, this is the layer of gel form, and this is the cement, and that is how a sandwich or layered reconstruction has been done. And this is 10 years follow-up of that particular patient.
Yeah. So Mandeep, the only thing that I don't do, which you have done, is to use metal, because I feel that by chance the patient gets a recurrence, then not having metal in, no K-wires, no screws, helps in getting a good MR done. And I don't think you really need to fix it because the construct becomes inherently stable when you do a sandwich reconstruction. The cement is there to support and buttress the graft that you put.
Right, sir. Right. That's true. So this is another patient where this something which is known as reconstruct was done. Dr. Agarwal would remember this case, I believe. I think this is the case which we did at TMH when I was there, sir. Do you remember this case?
Yes, of course.
So this is what you are saying.
When we started using struts and we realized that we don't have to use morselized bone at all. It just fills up completely.
Right, and this is where it completely filled up. This is how and as you can see, even the articular congruity has been very nicely maintained. So as Dr. Agarwal said, sometimes the tricortical crest, this part can actually collapse because you don't have a strong subchondral support. So this is strictly a surgeon. Again, I am re-emphasizing that surgeon to surgeon, it will change how they will reconstruct. As Ashish said, he would just put cement here. Even Chetan said he would just put cement here. And Dr. Agarwal said, no, I will certainly use subchondral bone graft. It differs from surgeon to surgeon how to reconstruct. But whenever there is very little subchondral bone left, if you supplement that subchondral bone with some more bone graft, you don't lose anything. However, you can do sandwich or you can do reconstruct. If you have availability of strut allografts, you can do a reconstruction as well.
Mandeep, there are three questions to Dr. Manish. Yeah.
Yes, sir.
Let me just make one point of comment before we answer those questions.
Okay.
For those people who think that putting cement is okay, think of a situation. We've gone through this several times before, and they get a recurrence in the subchondral area below that cement. I'm telling you, it's a nightmare to be able to deal with that situation. In trying to remove that cement, which is going right up to the cartilage, you can end up fracturing the condyle. You can end up creating a defect in the cartilage. So having a little bone always helps in the subchondral area, and that will probably allow you to do a sandwich reconstruction again if there is a recurrence.
Right. So now we can take the question, sir. Yeah.
The question is, when you do not have a bone bank, anybody has experience of using a titanium cage as a filler?
Sir, that question is for you.
Dr. Mukhi, Dr. Mukhi is asking.
Well, I know
titanium
Dr. Puthi
arms
is
cage,
very fond
arms
of
cage.
these titanium cages, and again, Ashish has said this. I'm saying it again. It's the principles which matter. What
Okay.
you actually use is up to you. A titanium cage is nothing but a strut which can take weight bearing and load sharing through that bone. And if you think that's something which works for you, by all means, go ahead and use it. Just remember that if you have to revise it, then removing that cage from within that cement is going to be hell of a job. So I have even stopped putting screws inside the cement, as they used to say, because I realized that cement is much easier to remove if you didn't have metal inside it. So if I have to use metal, if I need to support it, I won't use cement. I won't use screws within the cement, but I would rather use a plate outside because it's much easier to remove and then deal with the cement which is there inside. So these are all things that we have learned from bad experiences.
Any opinion on synthetic bone?
Well, it's too expensive to fill a huge cavity with synthetic bone. But if you want to use it for the subchondral area, I'm going to tell you a word of caution. I've used it in a couple of cases. We've had calcium sulfate coming out like toothpaste through the wound, and we've had seromas, and I have stopped using it. I think there's nothing better than cancellous bone. And when I need only a small amount of cancellous bone, I actually use a J needle and take it. I don't even take an incision. So I can get enough bone to just layer the subchondral bone with 2 millimeters of bone if I don't want to put a strut. And that's better than any bone graft substitute. Much cheaper as well.
Any use of denosumab before
surgery? Sir, we are coming to that. We have entire discussion on denosumab, sir.
Okay, fine.
Sir, as you said, this is a case where there is practically non-existent subchondral bone, and there are some, rents in the articular cartilage. This is a very young girl, only 21. She has already a recurrent giant cell tumor. So how are you going, Dr. if this patient comes to you, what will you do? Will you do a resection, or you will still go in and do a curettage? This is a 21-year-old girl.
Mandeep, you know my answer. I
asked Dr. Alok Agarwal, sir. Dr. Alok Agarwal, sir.
A long time you have asked me a question.
Yeah.
But looking to this appearance and the recurrence, I usually go for excision with reconstruction. I don't take a chance. Patients don't come back again.
Okay, sir. Dr. Abhijit Salunke. This is a 21-year-old girl, and there are rents in the cartilage. Will you resect or try and do a joint preservation?
So we'll attempt joint preservation. We'll give zoledronic acid or denosumab. Some better wall is formed, and then attempt curettage and cementing with plating.
Okay.
So young
Srinivas?
Yeah, I would, unfortunately, because the stainless steel, I would like to see an MRI because CT scan does not show the status of the cartilage. Yeah. What you're seeing is just the subchondral bone. But whatever said, the patient is still young. I would still attempt extended curettage and reconstruction.
Okay. Ashish?
2 inputs.
Yes.
Knee range of motion.
Knee range of movement, fairly good knee range of movement. She came to me walking.
Oh, really?
This is in 2009 pre-denosumab era. So we are not talking denosumab here.
No, I'm not even thinking of denosumab, frankly speaking.
Okay.
I think as Srinivas said, if MRI shows a similar disease and
there is no MRI, sir, because there are metal inside. We couldn't get an MR done.
Curettage
and reconstruction with
cement.
Only cement or sandwich, because there is no subchondral. Cement, only cement.
And plate.
Are you not worried about
instrumentation here? But yeah, cement.
Are you not worried about cartilage damage or residual cartilage damage with thermal or heat because of the cement, or you're not worried about cement penetration in the joint?
I am seriously not.
Okay. So you want to maintain the articular congruity. That is your most important factor for you.
Absolutely.
Yes. Agarwal sir, what will you do here?
So like I told you, Mandeep, I have remained constant over the last 20 years on this. I would always preserve the joint. It's on the lateral side. So even if there is a little incongruity, it doesn't matter. The patient still ends up with good outcome with their own natural knee than to put in anything artificial or than to fuse the knee. So I would curate this. I don't use denosumab for this because I don't think there's any value. We will discuss it in I think it is possible to restore that contour back by using a combination of muscleized and iliacrest strut to build up the subchondral bone. And then I would use it, I reconstruct it with a sandwich reconstruction. I think this disease is huge volume, so it is going to need some support with an external plate as well. So that's what I would do, but I would clearly preserve the joint. There's no question of dissecting this. Not unless the patient comes and tells me that I don't want to go through another surgery.
So this is something, this kind of a funny reconstruction. This is my own case. You know, this is in 2011 when I did this. Again, it was an attempt of joint preservation. Did a sandwich. You know, I had put in a kind of a graft here, a morcellized graft. Then I had put in a tricortical area crest, and then did an internal splintage, and then did a sandwich reconstruction.
This is still a T-construct, Mandip.
This is still a T-construct, but these are metallic.
Yes. So it doesn't matter what you do. Yeah. The whole idea is to support the subchondral bone and again support the cavity, the length of the cavity.
And if you look at the lateral view, there is a flattening. You know, I couldn't really, reconstruct the congruity of the joint. So what is going to be the prognosis? Any word on this? Ashish, you think this is going to work? Is not going to work? Pandit sir, yeah. This is going to work? This is not going to work. You are muted, sir. You are muted. Sir, unmute yourself. Pandit sir, unmute yourself.
See, the knee has already gone in valgus a little bit. So there may be more pressure on the lateral side, which usually is not the case. In a normal knee, it is more on the medial side. And the medial side takes the brunt of the weight bearing. But here, as it has gone in the valgus, it may, in a 2 years, 3 years, 5 years, it may go for orthotic changes. If not.
Kapoor, would you have done anything differently here?
Asking me?
Yes, sir.
Well, yeah, my first choice would have been bone grafting only. Bone graft and allogenic deep bone graft with the implant.
Okay. So, as probably it was not a proper reconstruction. It went into gradual valgus, and patient developed bad arthritis. It was difficult for her to even walk. This was a bad valgus deformity, and that is where we had to remove the whole thing and put in a prosthesis. Now, as I said, sandwich.
Mandip, Dr. Ashish wants to say something.
Yes.
Mandip,
yes.
Can we? I'm sorry, it's your case, and I don't want to be very critical. But
no, please be critical. That is why I kept this case. You be critical about it. Yeah.
Yes. One slide. Yeah. So no. The reconstruction, immediate reconstruction. The next. Yes. This one. See, if I see this X-ray, obviously I also do a lot of sandwiches. It's not that I don't do sandwiches, but maybe my indications are slightly different. So in sandwich, if we want to have good success, then I think what I will change here is what I'm seeing is that you have put that bone which you have put in the subchondral area is not very finely morcellized. That is number one.
Yes, probably. Yeah, this part maybe. Yes, I don't exactly remember.
So I have seen at least 5 to 7 cases where there has been collapse of this bone, this morcellized bone which you put in the sandwich method, and if it is not very densely packed, and as the success mantra given by Chetan, I will agree with him that we need to be very careful in weight bearing for this patient. We should delay it, and specifically if it is medial side. Second thing which I feel which I would have changed is, rather than having these 2 intramedullary nails, I would have put a plate. This is what I'm thinking.
Absolutely.
But, yes. Everybody is very intelligent in the hindsight, but this is genuinely, I feel that I would have done slightly differently.
Correct.
Yeah, Mandip, just want to add, I always wonder what happens to the viability of the bone over a period of time when you put do a sandwich technique. In terms of vascularity of the bone and the time it takes to integrate with the rest of the bone. What I've been doing is I've not done a sandwich techniques. I usually use a fibula strut to support it, and we've been using a plate which will buttress that graft to prevent it from collapse. We generally trying to overdo it and press the graft towards the subchondral bone area, just to prevent it from collapsing. And once you start mobilizing the patient, generally the congruity of the bone of the cartilage is restored. If we keep actively mobilizing the knee joint, the congruity is maintained, and 2.5 to 3 months of minimum non-weight bearing has to be practiced for this to be successful.
Thanks.
Mandeep,
Go back, Mandeep, I would give you one comment why this has failed.
Yes.
Go back. You don't have support for your subchondral area.
This one?
Yeah.
So, even the one before, yeah. So if you see, you have left a lot of the subchondral bone without any support. Now, had you put a plate which would have given you that support, or had you put an iliac crest strut which would have given you that support in that area, then that condyle would not collapse. So I think it's very important to support that area till the time the whole thing consolidates. Otherwise, this would have done well. And we've had cases like this where we have done reconstruction based on the same principles, but with support of the subchondral bone, and they have gone on to uneventful healing.
Thank you, sir. So again, this was another case wherein I attempted a sandwich. It didn't work. There's another case. These are all the cases with type C cartilage, where after the curettage, you are left with this kind of a, soft and deformable cartilage. There are certain places, there are rents also. And these are the cases where, my own ideology is to, because if you do something like this sandwich reconstruction, it has always failed in my own hands. Maybe I'm not doing the sandwich reconstruction properly and I need to learn it from the stalwarts like you and Chetan. But my ideology is to maintain the articular congruity. The more than is more important than giving it a subchondral bony support, because if you maintain the articular congruity, usually they do well. And to maintain the articular congruity in this kind of a soft cartilage, what you need to do is to give it a rigid support underneath the cartilage like this with a cement. And that is where in type C cartilage, usually I have started using only cement to maintain the articular congruity. On tibial side, it is more forgiving because of the presence of intact menisci. Usually patients don't have any problems. On femoral side, I've seen that, a little bit of flattening of the cartilage patients don't tolerate, and they come back to you with constant pain. So last words from you on this particular thing, and then we'll move forward to denosumab, sir.
Mandeep, there are two things. One is two questions are there, and Dr. Sudhir Kapoor wants to go. Can we take his case in between? Is it possible, sir?
Yeah, no problem, sir. I mean,
okay. The two questions. Two inputs are there from Dr. Pachore, sir. He has given input. How do you prepare the fresh frozen graft? It should be matchstick graft. It should be washed well so that the fat content gets cleared. That is the input by Dr. Pachore, sir.
Okay, sir.
In your previous case, the valgus occurred probably due to a minor fracture there. Was there a fracture minor there?
There were multiple fractures. I mean, the cartilage had a lot of rents at many places.
Okay.
And just because she was a young girl, I kind of thought of salvaging the joint. Yes. So, I mean, let us, because now we will have 4 cases to discuss about denosumab, because people have a lot of questions of denosumab. So what we can do is we can take cases from Dr. Kapoor, and then we can come back.
I hope you are comfortable. It is not a very important case. I can finish I can either skip it, leave it, or I can finish within 5 minutes.
No, sir, please finish it off. No, sir, you are there and it will be interesting for everyone to see, sir. Please finish.
Just share the screen. Automatically, this slide will remain there. It will overlap. You keep your sharing Mandeep like that.
Okay, sir.
So you do not have to go back to your this slide.
Yes, sir. Yes, sir.
I have allowed the multiple sharing.
Okay, sir.
Just share it, sir. And it will ask you to continue.
Yes, sir.
I'll take a very short time.
Yeah. Thank you, sir.
I'll just take 2 or 3 minutes. Basically, idea is
no problem, sir. Yeah.
This is my present institute where I'm working. Anyhow, that is besides the point. I mean, what do you do when you get cases like this? Operated already. Somebody has done a curettage and a bone graft which has failed. Patient has come to us very, 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 very late.
Yeah.
Any idea from the faculty?
Maybe Dr. Panchwak can take this.
Yeah.
Okay.
So, sir, I would.
Let me add one thing.
Yeah.
He was advised amputation at two places, one in Delhi and one in Patna.
Sir, can you share the X-ray first, sir?
Yeah,
X-ray दिखा दीजिए ना सर, बाद में discuss करते हैं सर.
This was the initial X-ray before the first curettage.
Yeah.
Yes, sir.
This was the history. I mean, operated, and then he came to me 2 years after the first surgery, and this was the X-ray.
Right. So this is one case where definitely we will be looking at resection. I read that someone had advised an amputation. We typically, if it's a giant cell tumor, we wouldn't really advise an amputation in these patients. We will attempt for a salvage of the hand, and we will have to do a resection in this particular case. And maybe it will be a good idea to give, initially it was not available, but now since it's available, I would probably use a few doses of denosumab over here. That will make the resection easier. And then I'll resect it. My favorite choice of reconstruction remains to be the ulnar translocation and wrist arthrodesis using a 3.5 mm DCB. That will be my choice.
By the people advised amputation was the tumor was going and involving the skin also.
Yeah,
and
usually, sir.
Large area.
Yeah.
See the.
Yeah, typically with such big masses, even if we have to resect a part of the skin, since the wrist sort of becomes a little narrower in size, the skin closure is not a very big problem. If there is a problem regarding the skin closure, we can always think of a free fibula kind of a reconstruction with a skin paddle that will give you adequate amount of skin. But in this particular case, I don't see any reason why there should not be an adequate closure after you do an ulnar translocation, and which just narrows down the wrist a little bit.
This skin has to go. The skin is fully involved. The tumor is just beneath the skin, and this is the previous scar, and there's some swelling here also.
Yeah, can we have the MRI, sir? Do we have the MRI?
Unfortunately, I don't have it, the MRI at the moment.
Okay, I feel that much of that skin can be salvaged except for that area around the scar. Much of the skin we should be able to salvage.
You have to take it from me. The skin was involved clinically and MRI wise at this place. The whole skin was involved. This whole skin was involved. There's no doubt about that. Since anyhow, but basically, I just want to convey one thing. Fortunately for this patient, if you review this patient clearly, all the vital structures of the hand are going on this surface, the palmar surface, and fortunately for the surgeon, the main extension is towards the dorsum. And this is what was done. The whole skin was involved skin. The skin was removed. At that time when I was working in ESI, I didn't have the facility of a plastic surgeon. The ulna was centralized, and I did the full thickness abdominal graft also. This was the tumor which was excised. At that time, denosumab was not available. The skin graft, the full thickness skin graft was done. And the limb survived nicely. There was no problem. Centralization of the ulna was done. Basic idea of showing this case is that amputation should be the last thing in GCT. If the palmar surface is relatively uninvolved, chances of succeeding are there. Third thing, now we have help of plastic surgeons everywhere. This is the full thickness graft which was done by me. It is not a difficult graft. All of us are doing medial head of the gastrocnemius graft to cover the upper end of tibia or upper end of tibia which has been reconstructed. This is an easy graft which can be done by any orthopedic surgeon, and it gives reasonably good results. This is the whole idea of showing this case.
Thank you, sir. I think we can take case from Dr. Gadegone also, because he is also having a case of distance of radius only.
Yeah.
Reconstructed that differently, and he also has to go for a surgery, I think. So I think we'll free him also. And
I'll take leave then, eh?
Yeah.
Thank you for your case, sir. Fantastic case, sir.
Thank you, sir. Dr. Kapoor, sir, thank you for contributing. Thank you.
Dr. Gadegone can.
Yes,
yes, done.
So should I start?
Yes, sir. Yes, sir. Please.
So this is the similar case. Now I am amongst all onco surgeon, great onco surgeon. I am a general surgeon. So the methodology and everything is something different. So just forgive me and don't comment on the procedure which I have done it.
No, it's good, sir. Please
So this is a 40-year-old male, bus driver profession 2009. This was a progressive swelling right hand dominant. Pain swelling progressive over the last 6 months. There was a night pain. I don't know what was the reason. Inability to perform activities of daily living. No findings suggestive of infective or other disorder. So this was the swelling. And this is the radiological finding 2009. X-ray shows expansile osteolytic radiolucent lesion without sclerotic margin and periosteal reaction. Diagnosis of radiologist lytic lesion of lower end radius with possibility of a giant cell tumor. And this was confirmed by the open biopsy was done that it is turned out to be a giant cell tumor. So what treatment today? We are doing something different. So this is for a discussion. Manish. Mandip.
Sir, I think you can go ahead.
Yes.
Because you know.
That is the problem. Okay, sir.
Similar cases, yeah.
So there was a distal radius. Is the third most commonly involved site for skeletal GCP. Goals of treatment are to achieve a satisfactory removal of tumor, lessen the chances of local recurrence, and to preserve as much as the wrist function possible. So plan of treatment was a resection and replacement with fibular graft. Resection typically was recommended for patients competency grade 3 with soft tissue involvement and collapse of articular surface. The bone defect was constructed by allograft autograft of the proximal fibula. Now this was all supported. 1911 was the first to describe the use of non-vascularized proximal fibular graft to replace the resected distal tibia radius. So before you do the resection, you must know the appraisal of anatomy of the lower end radius as well as the fibula, proximal fibula, because there is a very important structure, is a common peroneal nerve, and if you while doing excision are removing the fibula for transportation, common peroneal nerve and weakness of the lateral compartment is very common. That has to be, and therefore I put these two pictures that you must know the dorsal and volar approach for this thing. So this was the resection and replacement with fibular graft. This was the tumor 2009, post-operative AP and lateral view. The fibula was removed. This was transfixed with the ulna and it was kept with K-wire. Now the K-wire is not seen here. It was from the fibula to the carpal bones. And this is the X-ray. This is after 6 months. There is no resorption and nothing. It is going very well. So this is the radiological healed lesion with formation of a false radiocarpal joint here. This is 2012 and this is the X-ray 2017. And this is the excised tumor mass. Today still I have in my, that is in the container. So this is how it is a 2017. And you can see this the functional outcome. And he is able to do all sort of things, supination, pronation, and everything. He is able to do it. And you can see this is the video. Functional outcome at 2020. This is the today's X-ray. I called him because as soon as I get the phone call from Navin Thakkar ji, and you can see here. Another, you can see he can drive you. This is he's a bus driver. Wide embossed resection and osteoarticular restriction was effective in achieving local control and maximizing RMO. So this is, he has back to the work after doing this surgery. And you can see here, because I have put this picture today, it's nobody will believe that lower end radius after excision and fibular grafting will do this job. So I took an interview today And this is the interview.
आपको क्या बीमारी थी? उम्र वगैरह था? कहाँ? ये हाथ में। अच्छा, क्या तकलीफ होती थी? बहुत तकलीफ होती थी। दिन भर रात भर बहुत तकलीफ होती थी। चैन नहीं मिलता था, इतनी परेशानी रहती थी। अच्छा अच्छा, हाँ। तो अभी कितने साल हो गए ऑपरेशन को? ऑपरेशन को 10 साल हो गए। ओके। अभी क्या काम करते हैं? अभी मैं बस चलाता हूँ। ट्रैवल बस चलाता हूँ। ओके। हाँ। तो पहले क्या करते थे? पहले भी ट्रैवल था, अभी ट्रक चलाता था। अच्छा, हाँ। ट्रक के बाद में अभी मैं ट्रक भी चला सकता, बस भी चला रहा हूँ अभी फिलहाल। तो अभी पहले से बदले अभी क्या क्या काम है जो पहले कर सकते थे, अभी नहीं कर सकते? अभी सब काम कर सकता हूँ। कोई तकलीफ नहीं, कोई तकलीफ नहीं। मैं मोटरसाइकिल चला सकता हूँ, गाड़ी चला सकता हूँ, बस चला रहा हूँ, ट्रक चला रहा हूँ, सब चला रहा हूँ, कोई तकलीफ नहीं। आपको क्या भी?
So thank you very much.
Gade Ganesh sir, today follow-up was not with the COVID mask. So every time I get COVID mask and the recent follow-up. This is the beauty. You have a good context of the patient. So this is a recent follow-up.
Okay.
So you can see here. So this
Thank
is
you,
how
sir.
it
Thank you. Nice case, sir.
is.
This is what we don't really do these days. And maybe we'll come to that later on if time permits. Can we restart, sir?
Yeah. You go for sharing. It will be automatically, probably it will come to yours. Just share screen. That's all.
But
it will
I
overlap.
can't. We'll stop other screen sharing. Yes. Okay.
Yes. Do it.
Okay. All right.
Continue. So
Fine.
you are there, right?
Yeah. So I think I'll skip a little bit of the literature here, which says that cement does reduce the local recurrence rates as compared to bone graft. And, there is enough literature which says that cement is pretty safe. It improves the function, it reduces the recurrence rates. And as the notion that, it damages the cartilage, that is also kind of challenged in multiple papers, and which says that the osteoarthritis is more related to the size of the tumor and the thickness of the subchondral bone. And osteoarthritis is not related to use of cement. And even if many patients, they show the radiological evidence of osteoarthritis, they are usually not symptomatic. And that is why there is, kind of the cement, as Dr. Ashish said, is getting more and more popular. This is another patient which says that the nutrition of the cartilage comes mainly from the synovial fluid and not from the subchondral bone. And that is why, even if you have subchondral cement, it should not have any problem. But whenever you use cement in this kind of, as Dr. Agarwal just pointed out, if you don't use plate here, this is what you're going to land up with, because whenever the more than half the width is involved and it is reaching up to the supracondylar area, it is wise to supplement it with a plate to prevent the cement bone junction supracondylar fracture. Even if there is a recurrent lesion like this, if you have good articular cartilage and good subchondral bone left, you can still go ahead and do a curettage. Recurrent case does not mean you have to resect. Even if you have a Campanacci 3 disease, you can still do a curettage. Even if you have a pathological fracture like this, there is an intra-articular fracture here, just like any non-pathological intra-articular fracture, here also the principle would be to do a rigid fixation and allow immediate mobilization, do a proper deliberate arthrotomy, do a proper intra-articular reduction. Because you don't have any subchondral bone, you can just hold it temporarily with K wires, put cement in the cavity, which will itself then stabilize the fracture. And then you can expect a good range of movement and good function. This is another patient where this patient had a young girl, had a neck femur giant cell tumor. By the time she reached us, there was already a pathological fracture here. So what we did here was, did a curettage from the entire approach, did a iliac crest muscle pedicle graft, and this is how the fixation was done. This was immediate post-operative X-ray, and how it is beautifully healed. So choice of reconstruction depends on quality of available cartilage and amount of subchondral bone, though I would re-emphasize here that it is mainly related to surgeons' expertise and comfort. Maintaining articular congruity is vital. Cement reduces the local recurrence rate, but it does not cause aggravation of arthritis. Recurrent case, presence of path fracture or soft tissue mass is not a contraindication to curettage. Now coming to this case, I think we'll go a little faster, sir. I think it is 6:15. We'll try to wind up at 6:45 maximum, sir. Navin, sir?
No issue. You can go ahead.
How many viewers we have? at this point?
It was initially 1786, then it has reached to 2134.
Oh, okay. 2134. That's a good number.
Yeah, so it was a good number. Now somewhat reduced, but highest was 2134.
Okay, sir. So this is a case of giant cell tumor of the proximal fibula. Chetan, these are the images. Okay. What will you do? Chetan?
Sorry, one moment. Yeah. Can you go back to the?
This is the MR.
Sorry.
Say.
Yeah. See, what is the age of the patient?
He is around 25, 26.
Yeah. The problem with the proximal humerus is, resecting is not a option we would easily or consider very casually in the proximal humerus, because then when you do reconstruction, unless you use a reverse shoulder prosthesis, they will certainly lose all shoulder function. And here the articular bone is still intact. It is congruity is maintained, although there may be some sort of neck fracture of the humerus. I can't really be sure about that. But here I would think about using denosumab as one of the ways to take a chance with curettage in this. I would want to curate this patient and fix him and try to.
Yeah. You are muted.
So definitely, whenever possible, we have to try to salvage the joint. But as sir said, obviously this is a very, very borderline case, and maybe I would also like to use some neoadjuvant therapy before prior going into curettage.
Okay. Ashish? Ashish, are you there? No, I don't think he is there.
I think
Yogesh is there. Yeah, Yogesh
he is there, but he has muted and stopped his video also. Yeah, Yogesh bhai is there.
Yeah, so in this particular case, yes, I would like to use denosumab so as to make the curettage a bit easier. Definitely no resection in this particular case, but the routine dosing of denosumab I'll like to alter a little bit because we have now known that doing a proper curettage after using denosumab is a little difficult, and it also has very high local recurrence rates. So the dosing that we use is a little different if we intend to do a curettage.
Okay, we'll come to that, Yogesh. I just so you will also be wanting to give denosumab here. Srinivas,
yes. I was in two minds. I was in two minds whether to use denosumab or go for an upfront curettage. But here, yes, I will use denosumab, but not in the conventional dosing.
Okay, Srinivas.
I'm not a great fan of denosumab. Definitely, I would do an extended curettage. Here, since the alignment is not an issue, even if I have a bone loss, significant bone loss, if there's a deformity, I won't mind. I would go aggressively curettage this and support it with a fibula.
But Srinivas, as we know, proximal humeral GCTs are extremely vascular. You can't use a tourniquet here, and there is likely to be extensive bleeding. So if you do an upfront curettage, there are two problems here. One is bleeding and morbidity, and secondly, because of the bleeding, sometimes you can't do a proper curettage. So would you do something like an embolization or something before surgery, or you would?
Embolization is definitely an option.
But you won't use denosumab. You won't use denosumab.
Because the recurrence rates seem to be very high.
Okay.
So,
okay. Fine. Ashish is there. Ashish, are you following this case or you are not around? Okay, fine. So Agarwal sir, in this case, what will be your?
I just joined, Mandeep. Sorry.
No problem. We'll take your opinion next.
Yeah.
Agarwal sir, are you there?
Yes. So
yeah.
So Ashish knows what we started doing is even before the denosumab era, we would try to conserve it because based on the integrity of the periosseal shell, what you try to do is what we call it as an umbrella construct, where you take a femoral head allograft and you also take fibular struts and you try to give the correct shape to the humerus, maintain the valgus angle of the neck, and try to hold it in position. Today you've got good pre-contoured plates which you can use and hold it in position if you get that. Now I would use denosumab in this case, just like you said, is to reduce the need for using embolization. So I would use just 2 doses.
Only 2 doses.
Days apart, and that is enough generally to make the tumor much less vascular and to allow you to do a good curettage without actually making the bone very hard and making the curettage difficult. So that's what we've been using in cases where we want to use it, like for example, in the pelvis, or we want to use it in the sacrum, etc., where you don't want to give too much of denosumab to harden the bone, and you still want to give it enough that it becomes a little solid and it becomes less vascular so that you can curate it well. But yes, I would definitely try to salvage this situation for a young boy and try to reconstruct the humerus, knowing fully well that the recurrence chance is quite high. It's going to be much more than the 5% that we normally see with other tumors. Maybe here is maybe as high as 20 to 30%. But I would still keep that chance and go ahead and try to salvage.
Right. So basically what Dr. Agarwal said is that we know that denosumab, curettage after denosumab has increased recurrence rates, but this patient otherwise probably would undergo a resection with a much morbid reconstruction with complete loss of shoulder movement for the rest of his life, and he's just 25. So accepting that higher risk of recurrence and doing a joint preservation surgery, that is where the denosumab comes into picture. So this is what was done. There was this 4 injection Xgeva, that is denosumab, 120 milligrams subcutaneously were given at 0, 7, 15 and 20, day 0, day 7, day 20, 14 and day 28. So typically these 4 dosages were given, and this is how you can see the bone has nicely reformed all around. So now I have a bone all around to do my burring properly, because as every panelist has said, most vital part of your curettage is burring. And if you didn't have a good cortex or thicker bone to do burring against, you would not have done a good justice if you do a curettage. So now with this denosumab, what we have achieved is a good cortical bone all around, and that is where we will be able to use your burr more effectively. So Ashish, can you just tell the viewers what is actually denosumab?
Denosumab is a human monoclonal antibody which acts against rank ligand, and in basically what we understand is that it's a very potent inhibitor of osteoclastic reabsorption, and it leads to inactivation of osteoclast completely, and it also have static impact on the stromal cells as well. So in all, what we mean that denosumab is extremely potent drug which decreases the osteoclastic activity and in turn the bone resorption. Similarly, we were using bisphosphonates, and zoledronic acid was the main bisphosphonates which we were using earlier. But this the potential of denosumab is much higher as compared to zoledronic acid, and that's how we get those beautiful responses. But what is very important to understand is that it is not tumoricidal, and it cannot be considered as the definitive treatment. It is just an adjunct to the treatment to help you to do.
So that was my next question. So if it is so powerful, why can't we just treat the patient without any surgery? Why should we do the surgery if the response is so good?
Yeah, because as I mentioned, and there is literature as well, which clearly shows that the denosumab doesn't completely kill the stromal cells. The number of giant cells go down dramatically. And yes, this was the paper in JBJS which clearly mentioned that if the stromal cells are not exposed to denosumab, they will again start growing, and there's again a reactivation of osteoclastic giant cell happens, and this again leads to absorption of the bone. So ultimately, what we understand is that this is not the final treatment, and this is just an adjuvant to this is an adjuvant therapy, and we need to make sure that we treat these patients. And for unresectable, where the indications actually started the Amgen trial, which looked at the efficacy, safety, and the management, was actually for the patients which were unresectable, and they had propagated a lifelong use of this. So it cannot be taken as we give it for few months and then stop it. Once we stop it, and again we will have an increase in the disease.
Fantastic. So just a better understanding of viewers, giant cell tumor has two components, stromal cells and giant cells. Giant cells are produced by the stromal cells. Denosumab essentially kills only giant cells and not the stromal cells. And so that is why as soon as you stop denosumab, the stromal cells will again start producing giant cells. So it's a tumor is static and not tumoricidal, and that is why you have to do a surgery. So typically, this is what the purpose was, to do a, as you can see how thick a bone or the shell has formed after the use of denosumab. All right, so this is what was done, curettage and everything was done, and this is the function that we have at the end of around 4 years. So how different is it to do a curettage for post-denosumab GCT? Abhijit, would you answer this question? Why people are saying that, chances of local recurrence are higher if you do a post-denosumab cavity curettage?
The reason most probably thought is it gives good wall, and it gives a sense of false security for it, and you think that you have removed the tumor completely. So people think that it's normal bone, it's bit bleeding, and they don't go beyond that. So in curettage, in denosumab setting, you should go beyond that wall, which is falsely formed.
Okay.
So radiologically, your assessment should be that you should go beyond what is seen, and use of IIT will be helpful in these cases.
Fantastic. So Agarwal sir has a lot of experience with curating a post denosumab giant cell tumor. So, and I have witnessed a couple of his lectures where he was talking about the ways to reduce the local recurrence rates after denosumab. Sir, can you just elaborate a little bit on these things?
Well, I think let's first understand what we have learned with denosumab. I think when it came in, we were all very excited about it. We thought that it's the medical treatment for giant cell tumors. And then we started using it in more and more cases. In fact, we started using it in almost 70% of our cases, or let me say, anybody who could afford it, we started using it thinking that it makes the curettage a little easier and it would probably help us control the tumor. And then all new knowledge started coming in about what Ashish has shown, that the neoplastic cells still remain viable, and that if you didn't curate the tumor, you're going to get a recurrence. And if you didn't curate a tumor completely, you're still going to get a recurrence. And we actually published our data in CORR, and we were probably the first ones to show that the local recurrence rates actually increased when you use denosumab instead of reducing. And that set us thinking, and we realized that you get irregular ossification when you give denosumab, and therefore when you think that you've got good bone when you're burring it out, but there is actually tumor beyond it. And so unless you use a image intensifier and go to the actual boundaries that you had before starting denosumab, you're not going to clear the tumor, and you can risk recurrence. So what we have started to do now is to use it very judiciously. First of all, we don't use it for most of our standard curetages. We would use it only in a case where, like we said in this one, we want to reduce the bleeding. We want maybe some kind of a rigidity so that you can do a good curettage. Then we would use it as few doses as are necessary to achieve the objective. So you need to define what is your objective of giving denosumab, and the moment you have reached that objective, you stop denosumab. So you use minimum number of doses. And then when you curate, make sure that you've got the entire disease out by looking at what the imaging was before starting denosumab. And the boundaries have to be the same when you use the birth. You still end up leaving a very thin shell, and then you reconstruct the cavity that you have.
Thank you, sir. Thank you very much. So this is typically, this is how typical GCT looks when you do a curettage. When you do a curettage of a post-denosumab, this is how it looks. It practically looks like a fibrous tissue. You don't see any similarity to the typical giant cell tumor. So this is where anybody who has curated a fibrous tumor will know that you don't know whether you are actually taken out disease completely or not. And that is where, there are very high chances that you leave behind really gross disease. And that is where the local recurrence rates were reported to be very high. So if you look at some initial literature, this is one paper which says that local recurrence rates are almost 60% as compared to what otherwise we would achieve. This is the paper Dr. Agarwal was talking. This is his own paper. Is published in CORR, where he has reported local recurrence rates of 44%. Exactly the same Dr. Gulia and Dr. Puri has reported from Tata Memorial. The recurrence rates are as high as 44%. Now, if you, I mean, the other thing is that don't look at this percentage of local recurrence, which is very high. You should think like, otherwise this patient probably would have lost the joint. So if the local recurrence rates are 44%, that means that 56% of the patients who would have otherwise lost the joint could be preserved. And even from those 44% of patients, maybe half of them would again you will be able to curate and preserve the joint. So ultimately 8 out of 10 patients who would have otherwise lost the joint, you ended up preserving the joint. So that is where the advantage of denosumab is. In borderline cases where you think resection is the only answer, you could probably do a curettage. Now this is another case. This is a proximal end of fibula, large giant cell tumor. Dr. Srinivas, how comfortable? Yes, Ashish, you want to add something? You are muted.
Yeah, Mandeep, denosumab is something which I'm very interested in, and I've been looking at the data very carefully. And so I have a take on this, which I would like to share with everyone. I sincerely feel that we have not reached at the level where we rightly know the indications of using denosumab. When denosumab came into picture, everybody started thinking that it's a magic drug, and we started using it left and right. I've spoken to a lot of colleagues in Canada, States, Europe, and everybody have now started realizing the same thing which Dr. Agarwal said, that life doesn't become easy in every case. Rather, life can become difficult also if you start using denosumab in each and every case. But what is very important to understand is that when we were using this drug in the beginning, we were not sure how to do the right curettage. We were not sure how to use this drug correctly. We were not sure how much of drug to be used. Till today, we are not sure what should be the correct frequency, not just for the curettage, even otherwise as well. So I think today, this is a pendulum which swung to one side. People got very scared that it causes high rate of local recurrence, as Srinivas said, but that is not the case. And then looking at bad results which Canadian group published, we again swung back to the other side. But I think with the time, we will come back in the middle to understand the right indications which will be required.
I'm sure when Tata and Hinduja again publishes after 7 years, the local recurrence rates would be in range of 10 to 15%. I'm 100% sure about it.
Yeah. And as you rightly
are getting
said,
more redefined.
Yeah, and as you rightly said, the inclusion criteria is extremely important. If you are giving it to the patients which are borderline resectable, then you are saving a lot more joints. So rather than looking at local recurrences, maybe you should see how many joints were saved which have not been saved otherwise. So I think these are points of discussion which should be thought in future. And I think we should collect more data on this from various institutes, looking at the inclusion and exclusion criteria, and then make the right call.
Thanks, Ashish. So now let us come to this case. This is a large GCT of proximal fibula. Srinivas, you're going to resect this fibula. You will resect it up front, or here you would use denosumab. Are you around, Srinivas? Okay, he's not there. Yogesh, you can take this one.
Yeah, I can take this one. Definitely, I'll be denosumab. Mandeep, can I ask you what's the status of the common peroneal nerve?
Oh, it's functional. CPN is absolutely functional. Yes.
So I will be using definitely preoperative denosumab in this particular case, and then planning for a resection.
What will be your purpose? Why you want to use denosumab here? You are anyway going to
make, yeah, if you see the soft tissue extension, it's pretty big, especially in the posterior compartment. I want to make that resection easier, avoid spillage intraoperatively, have a good capsule formation so that I can resect it completely, because this is going to be a marginal resection, definitely, in order to save the neurovascular bundle.
Dr. Kundu has raised a finger.
Yes, Dr. Kundu. Yes, sir. Sorry, I
Yes. No problem. But I'm also along with Dr. Yogesh. Previously, I have never used denosumab when it was not available, and people reject these tumors. But in this kind of cases now, because denosumab is available, it can be very well marginalized. It becomes thick, and probably there is no spillage. And in this case, we can give two incisions, particularly in this case. One from the middle side, for common pronil, and from the medial side, we can save the posterior tibial artery and tibial. So we can give two incisions in this case.
Yes.
So we can resect it easily, but it is a difficult case because it is overhanging on posteriorly and a little bit on the medial side also, and we should be very careful about the posterior tibial artery and tibial now.
Okay,
and we can save the that. So we can use two incisions in this case, one medial and one lateral, and we can resect it and then we can reconstruct. So this
fantastic.
is expandable.
Fantastic.
Yeah.
Fantastic. So here, I mean, Dr. Agarwal, you will also use denosumab, or you would be kind of okay? You were anyway resecting these tumors before. There was no denosumab. When there was no denosumab, we are all resecting this. Now with denosumab, why should we use it if it is available?
Well, it reduces my blood pressure for sure.
Okay.
Because denosumab creates a nice hard shell, and I can dissect the nerve away. Now, these tumors, as Dr. Kundu very correctly pointed out, they may look easy, but they're extremely difficult.
Right.
And if you damage the trifurcation, the patient will end up with an amputation. So this is something you have to be very careful about. You have to painstakingly dissect the trifurcation. More important than the nerve is going to be that you have to identify the entire posterior tibial before you ligate anything which needs to be anterior tibial or not a part of that. And at times, because of this big soft tissue component, you may find that it is actually encased after you have given denosumab within the soft tissue mass. So you may actually have to split the tumor open, take the bundle, and then go ahead and resect it, which will be like, it's not a complete wide resection, but in GCT, you can take that chance if you're going to save that leg.
Right.
So I would definitely try and dissect it. I would definitely use denosumab. And here I'm not scared of using just doses. I can use more doses. Till the time I feel that there's a good cell around the tumor, I would use the denosumab, probably 4 doses. I would use and then go ahead and resect it out. But be very, very careful. And I also keep a microsurgeon available to me in case I need him to repair or reconstruct the posterior tibial vessel, which is at risk.
Mandip.
Yes, sir.
Mandip.
Yes, sir.
Any role of embolization if denosumab was not available, or even today?
So today's,
to make the tumor smaller.
Deoperate, okay, embolization. Okay. I mean, sir, you Dr. Agarwal, Dr. Pandit is asking if should you use definitive embolization to reduce the size if denosumab is not available.
Well, we did use embolization in a few cases initially, and I can tell you that I have not been very happy with the results.
Okay.
There are very few people who actually had tumor shrinking or the tumor coming under control, even though we were using serial embolization. So I think embolization is not a reliable way of controlling the tumor. I would use embolization solely if I have to use it in combination with denosumab for an unresectable tumor. Then I would use it. Otherwise, it's not going to be my primary go-to option.
So see, as you can see it from here, you know, it's beautifully shrank and it became quite small. I mean, the thing really started looking very encouraging. We couldn't really save the deep peroneal nerve, but the superficial part of the peroneal nerve could be saved. The tumor could be taken out very easily. So this is again another indication where your resection has been facilitated by use of denosumab. It is not that you converted a resection into curettage, but your resection became more safer and more, maybe less morbid. Now this is another case, 39-year-old male, huge GCT, bowel and bladder is completely involved. Patient does not have any bowel bladder control. So what will you do here? I'll take this, I'll ask Dr. Chetan. In this particular case, what will you do?
Hello?
Yes.
Dr.
Yes,
Kundu has a
yes.
similar case, I think. Mandip.
No,
Yeah.
no, that's a pelvis. Pelvis.
That's a difference.
Okay.
Yeah, this is a
Yes,
huge mass, and honestly, this was always a dreadful cases to deal with. But I think denosumab is something which has, saved us a lot of trouble
Yes.
in these kind of cases. I would certainly start this patient on denosumab
Hmm.
and see how they respond.
Hmm.
And eventually, this patient will need some other local adjuvant, which may be either in the form of this patient. If the patient recovers bladder and bowel function,
Hmm.
then I would either think of serial embolization along with denosumab or definitive radiotherapy.
Okay.
If the patient doesn't recover bladder bowel function, and I'm sure it is gone for good, then even resection is an option that I may consider.
Okay, Srinivas is he has done a lot of sacrectomies. So today, when you have denosumab available, would you do a surgery, or you would put this patient on denosumab, Srinivas?
This particular patient, definitely denosumab and angioembolization is the first line of treatment. I can see that the lesion is S3 and below.
Yes.
So I think there's a surgical role as well. Once you shrink that lesion, make it less vascular, we can go ahead and do a partial sacrectomy in this case.
Yes. Ashish, how long will you do? Will you give denosumab here, Ashish? Okay, Agarwal sir, how long will you do? Will you give denosumab here?
Yeah, Mandeep.
Yes, Ashish. Are you there? Okay, I didn't see you. Sorry.
No, my video has been shut. I don't know the reasons, and I can't start my video.
Okay. Previously, your voice was cutting. That's why we had stopped it. Sorry. Now, again, I'm asking you to start your video. Bandwidth was a problem.
Yeah, Mandeep. Sorry.
Yeah. How long will you give denosumab here?
So I think first we need to define the intent of the treatment. And intent is obviously curative, but what is the final goal? Are you planning a surgery, or are you trying to definitely treat this patient with denosumab? But I think, as Srinivas said, because it is S3 and below, and if denosumab along with angioembolization can give a nice reduction in the size, and if we can do a easy surgery, then I think it will be worth trying complete excision. Because if we do not do that, then chances of its local failure are pretty high. Though we have started treating the axial giant cell tumors with a combination of angioembolization and denosumab, but I think if they can be resected without much morbidity, they should be resected with R0 resection.
So this patient received 4 dosage and 2 more denosumab at monthly interval. 6 doses and 3 months. This is the picture. Patient did not recover any bowel, bladder, or sexual function. Patient still has retention of urine. Patient still has constipation. Patient has not recovered any neurological function. We have waited for 3 months. What are you going to do now, Ashish, for this case?
So, I'm not sure that, whether this patient will recover back or not. But the point is, if you need to look at the long-term good control and the quality of life later on, then if resectable, then you should resect it. Anyway, this patient has lost bowel and bladder. So I think if you can, and I think I'm seeing a decent response from the images which you have put, both the SAG and the axial images. So I think we should go ahead and do a sort of sacrectomy through lower end of S2.
Okay, sir, Agarwal sir, would you agree with the plan so far, whatever has been done, or you would have done something differently? Dr. Agarwal? Is there? He's not there. Okay, fine, no problem. I think he's not there. Okay, he's around. Okay, sir. Sir, would you agree with whatever has been done, or you would have done differently?
I hate sacral giant cell tumors because
all of us
it makes me look very inferior.
Mastura.
It's a case where I have failed the maximum number of times, and I don't think this is a case where curettage is going to work. So if anybody is thinking of curettage, I think they should just shelf that idea. The only thing which is going to work here is a resection, and I agree with everybody on this. And the choice is between taking denosumab for life or in doing a resection and accepting the bladder bobble deficit that is certain here. Anyways, here, even if you had planned before, even if you didn't wait for bladder bobble to recover, it would have been a S2 and below, you would have lost both the S3 nerve roots and with a very high risk of incontinence even otherwise. But it's still something which is worth doing instead of taking denosumab lifelong, because we still don't know what are the long-term consequences of denosumab. This is something to understand. It's very easy to say that we'll give it for life and stay away from surgery. But I think wherever it is resectable, if it was me and I have to take a decision for myself, I would not like to take denosumab on a lifelong basis. I think resection is a fair alternative.
So that is exactly what was done.
Also,
was done.
Mandeep,
Yes.
as Dr. Agarwal said, that it's a new drug and we don't know about the long-term side effects. In addition, there's a huge cost implication as well.
Yes, yes, absolutely, absolutely. I think because every injection of denosumab costs 23,000 rupees for the information of viewers. It costs around 23,000 rupees every injection. So we'll come.
We just analyze our results of treatment of angioembolization and denosumab for unresectable. We've got response rate in about 70% of the patients. That is the response rate. But the local recurrence rate is nearly about 50%. So, you know, half of them will anyways again require some sort of other treatment, either re-challenging them or continuing lifelong. So you just can't sort of fix it here. And as discussed, that if it can be resected completely, please do so.
Okay.
Well, I'll let you in on a secret. I have 3 patients who have not responded to denosumab, embolization, bisphosphonates, and a combination of these things. And I really don't know what I'm going to do for them, because surgery itself is going to be very difficult because they're tumors which are extending up to L5. And some of them are even beyond that. So even resection is a nightmare there. So I think if you have a tumor which can be resected, I would grab that opportunity and not wait for it to become out of control.
So this is another case, 40-year-old female, huge anterior mass, presented with ball bladder loss, gave her denosumab, it almost completely shrank and she recovered ball and bladder completely. So here, my dilemma is whether to go in for a surgery or to treat her with continuous denosumab, and then how long? You know, any of you, I mean, maybe Dr. Agarwal can take this question.
Yeah, it's a dilemma, but I would err on the side of doing a resection for the sacrum, simply because it's not easy to get a second chance. If you end up with a curettage and it recurs and it spills, then I think it's going to become a very difficult resection subsequently. So like I told you, in a sacral giant cell tumor, when I have the enemy by the neck, I'm not going to leave it. So I would end up resecting it. Maybe you can try and save the S3 roots and then go down and resect this out. This is one case where you can save the S3 roots, it looks like, on that.
Sir, we counseled the patient about the same. She was absolutely, unwilling to let go the ball and bladder function now because she has just regained.
But she doesn't know what happens when.
Yeah. So, but what I'm asking is, can't we treat her with serial embolization or radiotherapy for that? Because we need to attack or kill the stromal cells. Now,
I am very, very scared of a malignant change when you combine denosumab and radiation, because both of them can cause malignancy by themselves. We've seen it, and I would be very scared of using the radiation. Plus, in a young girl, using radiation in the pelvic area has its own complications in terms of side effects to the gonads and infertility and all those things. So I don't think radiation should be considered in a very young patient unless you have no other option. If you had everything which has failed, then I would use radiation. Otherwise, I think the best option is to resect it out.
Okay, Ashish, what's your take on this? I sent this patient for embolization it was sent back to me by the intervention radiologist saying that there is no vascularity. I can't embolize anything. So embolization was thought of, but it was not done. So now what would you do here?
So, if there is no flush and if the symptoms have gone down, if you are seeing nice ossification, I don't mind waiting for some time here. But it's as Dr. Agrawal said, that it's a double-edged sword. It is extremely difficult. If this goes a bit up, then whatever bowel bladder you have, you will lose that. Point number two, that your chances of preserving with resection will dramatically go down if it reaches S2. So if you plan to wait and observe on this patient, and as I already said, that only 50% of them will stay like this and remaining will increase, it's just a call. Either you operate them or just observe them and discuss with the patient and they call. But if you are observing them, this patient has to be on MRI every 3 months.
Mandeep,
yes, Srinivas.
In a few cases which have used denosumab, in such cases, once there's a recurrence post this, it tends to become very resistant and difficult to treat. To go back and put
reckless.
them back on.
It's vengeful recurrence.
So so we should not give this tumor another opportunity to even recur. Even if there's a chance of it 50% coming being under latent stage, I think I would not take a chance in these tumors.
That's
the other point,
what I said, when you have your enemy by the neck, it's the time to deal the death blow. Don't wait for it to become a monster.
And more important is the level in this case.
There is one question. There is one question of denosumab.
Yes, sir.
After the curage, in the gel form, can be a local denosumab can be used? Is it effective?
No.
No.
It's an antibody. You have to understand how it works.
Don't even think about it.
Yeah.
No.
Somebody has asked. I don't know his name, but he has asked it.
Good.
I think it is Dr. Mukhi's son. Dr. Mukhi's son.
Okay. Fine. So this patient discussed all the options, and we took radiation oncologist's opinion, and he said radiotherapy. Audible? The things are visible? Hello?
Yes.
Yes. Okay. The radiation also gives 90% disease control rate, 1% risk of malignant transformation. So inoperable and morbid surgeries can be safely avoided with radiotherapy. Having said that, as Dr. Agarwal pointed out, we don't have any data on radiation in a denosumab given patient. How they will, that combination might, come up with. So anybody would be very, very worried of giving radiotherapy, but this is what was done in this particular patient. And then she was put on oral bisphosphonates and she's controlled at 4 years of the treatment. Now, this is again indigenously devised plan for this particular patient, and we don't know what is going to happen in future. So this is what, Ashish was saying. We don't know how long we have to take it, how long we have to give it, but there are a lot of issues with denosumab. And what are the issues? Denosumab withdrawal is associated with high rate of subsequent tumor recurrence. Prolonged treatment can cause atypical stress fractures, critical hypocalcemia, and osteonecrosis of jaw. And pediatric use in less than 12 years is not recommended. We also have the case reports that denosumab can cause sarcomatous transformation. So it's something which has to be used very judiciously. So take home message 5, denosumab helps preserve joints in borderline cases. It can facilitate resection by downstaging the disease, may help do more function preserving and conservative resection. GCT at difficult, inoperable, or morbid sites can be controlled with long-term use of denosumab. It is certainly indicated in metastatic GCTs, but post-denosumab curettage is technically more challenging. Local recurrence rates are higher, and that must be counseled with the patient. And it is only tumoristatic and not tumoricidal. So surgery or embolization or radiation is must to cure a GCT. All right. So this is where Doctor, I'll ask Dr. Thakkar whether we should end here or there are a couple of more.
No. I think US case of Dr. Alok Agrawal is remaining.
Yes, that is what I'm asking.
He is going to, go ahead, no issue, sir.
No, so I can just run through. There are only few slides about resections. So I'll just run through them, and then Dr. Alok Agarwal, because just for
okay, no issue.
Mandeep, there's one point which I wanted to make when those two cases of distal radius tumors were shown.
Yeah, so that is what
I think we have still not got the message that we can use the ulna as a graph.
That is why this further case, there are few cases which I have kept, and I will actually show those things in that.
I think we need to have a webinar purely on a distal radius giant cell tumor with all the various scenarios.
Yeah,
I think that people have to understand that you don't need to take the.
There are also two questions about that distal radius. Does the vascularized proximal fibula better than the non-vascular fibula graft in that?
So let me finish off the cases, and then we can.
Okay. Then all the questions will be taken together. Okay.
Yes. So there are cases where you can't do curettage and you need en bloc resections, and when you do a resection, you need to reconstruct those defects. So typically, around the knee joint, using a megaprosthesis is the most suitable and most encouraging options. Why? Because it gives the patient immediate mobility, immediate stability, and currently available implants are very good. They last pretty long. They give a patient very nice function, and that is where there is our usually the first choice. In proximal humerus, usually, as Dr. Chetan pointed out, when you resect a proximal humerus, you lose deltoid, you lose axillary nerve, and that is where you usually don't have any function at the shoulder. But in giant cell tumor, because it's a benign tumor, we can go closer to the bone while we don't need to really take wide margins. What we can do is take just marginal margin, preserve the axillary nerve, preserve as much deltoid as possible, and then you can reconstruct that with a reverse glenoid type of megaprosthesis. And that is where you can get a reasonably good function at the shoulder joint. There is again, you do more function preserving surgery because it's a benign tumor. We just saw two cases of distal nerve radius GCTs by two colleagues. One had used ulnar translation or centralization of ulna, and another, Dr. Gargone, had used on ipsilateral fibula head. What we have been doing is something known as translocation of ulna. So what it is, you resect the distal end of radius, osteotomize ulna at the same level, translate the ulna to bridge that defect, make sure that all the muscular attachments remain properly with that translated bone, and then you put in a plate and do a plate from metacarpal to translated ulna to radius and do a wrist fusion. What it does is that because of the translation of ulna, patient gets something like a direct procedure, and that is where you get this beautiful pronosupination. So when you do a good pronosupination, when you have an excellent pronosupination, you usually don't suffer having loss of wrist joint. So this is where this is another case where you can have a nice pronosupination, and these patients don't complain of any loss of wrist movements because they have good pronosupination. The brand ambassador of this surgery is the sculpture of the Dabbawala statue, who has been operated by Dr. Agarwal. There is a beautiful statue, huge statue at the Haji Ali in Mumbai, the Dabbawala statue, very spot. The sculpture of that statue has undergone this particular procedure. His wrist has been fixed, and translocation of ulna has been done, and he doesn't have any problems. Now, the problem with centralization of ulna, what Dr. Kapoor said, is that you don't have any pronosupination because you are fusing ulna to the carpals, and that is where you don't get any pronosupination, and that is where these patients usually don't have good function. Another thing I would want to point out from that particular case is that we are very much worried about doing pedicle flaps in this kind of a flap, abdominal flap in tumor cases, because you are keeping a tumorous area in contact with a non-tumor area for a very long time, and God forsaken, there might be seeding of those tumor cells, if there are any, to the abdominal area, and there can be a implantation giant cell tumor there. So we are really worried about doing those kind of procedure. Coming to the coming to the fibular hemiarthroplasty. Now, the globe, all the oncology circuit, we have practically stopped doing fibular hemiarthroplasty. Besides the donor side morbidity and a risk to common perennial nerve, there are three essential problems with that procedure. One is stability of the wrist, second is degeneration, and third is non-union. Now, all these three, even if you look at that particular patient, that patient has an excellent function. The MSTS scores may be very high, but there was instability. The range of movement was not complete. The dorsiflexion was seriously restricted, and that is where those and if you look at the literature, if you put together all these three complications, instability, non-union, and degenerative problems at the wrist, the total 45 to 50% of the patients will have one of these or two of these or three of these complications. So that is where we usually don't do fibular hemiarthroplasty. Of course, it's very exciting procedure, and what Dr. Gadgone showed was quite encouraging. Say, fibula again, you can do something like a translocation of fibula after resecting the tibia, and you can have a good ankle fusion. And there are these areas where you have expandable bones. You can just remove those bones and do not really need to reconstruct that. So thank you very much from the bottom of my heart. All the panelists, I really thank you for very active participation. And Dr. Agarwal, Dr. Ashish Gulia, Dr. Chetan, Dr. Yogesh, all of you, thank you very much. Jamin, Abhijit, I'm sorry I could not really reach to
Dr. Alok, can you share the screen so that meanwhile that
and
time we
Pandit
can
sir,
ask the questions.
thank you for being there. You're always there. Your inputs are really value addition.
Can you share the screen, please?
I will request.
Sharing it.
Okay.
Dr. Alok, just 1 minute before you start. I will have some final words from Dr. Ashish and Dr. Agarwal on this particular webinar and what take-home message they want to give to our viewers about GCTs.
Yeah, definitely.
Yes, Ashish, you can start, and then we can ask Dr. Agarwal to. Are you there, Ashish?
Hello.
Ashish,
Dr. Ashish.
He doesn't seem to be there. Oh, Dr. Agarwal is also not there, or what?
No, Dr. Agarwal is there, but he has muted himself, and also his video is off.
Okay, no problem. Dr. Alok, you can start your case, and meanwhile I'll ask Dr. Agarwal on my phone.
Okay, fine. So it is a case of giant cell tumor of the proximal humerus. So in the year 2000, a 23-year-old female came with a history of pain and swelling in the left shoulder and presented to a local orthopedic surgeon. The case was diagnosed as a case of giant cell tumor of the proximal humerus.
Just keep your mic near the mouth so that your voice is more clear. Just hold it. Yeah.
Okay. This is the case on presentation of a 23-year-old female. It was diagnosed as a case of GCT in the year 2018.
I may have to stop your video to get your voice clear, please. Okay?
Okay.
Your voice will be clear now. Bandwidth is low. Okay?
Okay.
Go ahead.
So any suggestions how to go about it?
Dr. Pandit sir, do you want to say something about this case? Unmute yourself. Pandit sir, unmute yourself and then comment on this X-ray.
Yes, it is an expansile lesion of the upper end of the humerus, and biopsy has to be done. But before that, MRI has to be done to see the nature of and make it more clear.
That is it. In the year
there already seems to be developing pathological fracture at the neck of the lesion.
Yeah. So in the year 2018, there was neither an MRI nor the skills of curettage or denosumab there. It's 2018, and a local orthopedic surgeon did a curettage with grafting. And this is the post-surgical picture. Well, all of us are very clear that it may not have been complete. No cauterization might have been there, and even the grafting is not good or supported.
Right.
Okay.
So we know that it will be having a recurrence. So he had a recurrence, and then he was again treated in this manner. But there has been a bone grafting done, and with a tubular graft strut support in 2003.
Okay. Do you want anybody's comment now?
Is this
Somebody-
X-ray? Is this X-ray a few months after the?
No, it is after 2 years of the surgery.
No.
The surgery
But
was
in the
2001.
follow-up of how many days after bone grafting?
See, this was the recurrence. Surgery was done in 2001. And
Right.
this is almost after 1 year.
But there seems to be some lysis in the fibular grafts at the lower end.
Okay.
Yes, somewhere there. So these grafts are not well taken up, and there seems to be some erosion of the graft.
Your point is very well taken, sir. It is really what you were saying.
Upper
Maybe
part is okay.
correct.
Upper part looks okay.
Yeah.
Right.
And then this is in 2007 when the patient came again with pain and swelling in the shoulder. And you can see there is an osteolytic expansion coming next to
yes.
the graft,
Mm.
suggestive of recurrence. Now what to be done at this juncture? Already two surgeries are over.
Dr. Kundu, do you want to say something now?
Yes, this seems to be a local recurrence, and it should be biopsy, MRI should be done, and then biopsy should be done. And if come out to be GCT, then resection of the upper end of the humerus should be done. Because it's already two recurrences.
At this
and
time,
now
what happened?
Yeah, because it is very difficult along with the bone graft. It is very difficult to find out the
Yeah. So this is the recurrence, and these appear to be sinuses.
places where the recurrence may not occur once more.
This patient also had a discharging
Was there an infection?
Okay.
Yeah, that is it.
Okay.
So the patient had a discharging sinus suggestive of infection, and a sinogram has also been done. Now, Dr. Kundu, what
case, what the biopsy done, some curettage was done, but it was a bacterial infection, or sometimes in our country we should rule out tuberculosis also.
Okay.
If it infect, and the infection is not settling down, then we can curate it out and fill it with some biopsy. If recurrence, then the upper end of humerus.
Okay.
So it should.
Okay. So this case was taken, and a thorough curettage was done, and then cementation was done with antibiotic cement.
No, before curettage, whether biopsy was done or not.
Sir, I'm giving you the history. So by history,
Okay.
it appears that this has been done. This is a post-op X-ray which is visible.
So these are the X-rays of the previous surgery.
Yeah.
You
Last surgery, 2008 surgery.
Okay, you inherited this case. Okay.
Yeah. Okay. This case comes to me in 2017.
Okay. Go ahead.
10 years, and this is the picture that she's having an infected wound with a bad odor and socially isolated and pus pouring out for the last 10 years.
Oh my goodness.
And how do we go about it now?
Latest X-ray.
Now there is X-ray of 17. Yeah.
X-ray of 2017, please.
Let me see whether I am having it or not.
Go ahead.
But this is what was done. We went for a two-stage procedure. The first stage excision was done with an antibiotic spacer. That is the tumor excised. And this is the second stage reconstruction with the metaprocess.
Your bandwidth is low. Internet bandwidth is low. That's why your voice is cutting. Okay.
Yeah. And this is the follow-up now. The lady is happy, and she can do function with the elbow and hand. And of course, we all know that in infected case, doing a joint would have not been proper. So this is
In this case,
Yeah, please speak.
Yeah, in this case, instead of this prosthesis, I would have gone with nail cement spacer and the antibiotic cement along with some vancomycin, and that would have been better instead of putting this spacer as a prosthesis, because it was already infected and it was a very recalcitrant infection. So it would have been better that resection. Okay.
See what happens once you take this out, you put a spacer, you wait for 6 weeks to do an ESR and CRP to find out whether it is infected or not. And that is the time, ideally between 3 to 6 weeks, and take out the spacer. And then you
But
go
in
for a
between,
spacer.
it
Instead
was
of
a
bone.
two-stage surgery. Two-stage surgery. You had to put a spacer with the antibiotic that
Yeah.
Dr. Kundu has suggested.
So that is it is a two-stage surgery that we have done.
Okay, but at that time you had put an antibiotic spacer or not? That is
Yes,
the
yes, he had put, he showed, he said he's put in.
Okay, okay.
First stage
He had put
excision
cement
with
only in
antibiotic
this.
spacer. Second stage reconstruction with megaprosthesis, and that is the happy patient now with a follow-up of 2 years. She is doing good.
Wonderful, wonderful. Good case, sir. Good case, sir.
2017 to 2019. Yes, very good case, Dr. Alok Agrawal.
Thank you, sir.
Yeah. Okay.
Fine. So
Can
let's
can I show one case? 3 slides only.
Yeah. Dr.
Yes, yes.
Kundu wants to
Yeah,
say
Dr. Kundu.
something. Yeah.
Absolutely.
Okay.
Should I go from here? Your bandwidth is very low.
Okay. I'm sharing. I'm trying to share it.
But you will not be able to share it, Dr. Kundu. Your bandwidth is very slow.
Okay. I have sent the slide to you, sir.
Okay. I am just trying.
On your email.
I'm just trying.
Okay. But video will not be there because it was slightly larger size. Just a case of. Okay.
No problem.
No issue. Video will not
Sir,
work, but other thing will work.
Sir, by the time you put out the case, maybe we can have final words from Dr. Ashish.
Yeah, it is coming.
Yes. 100%, sir.
Yes, sir. Ashish, about this webinar and treatment of GCT.
He has only 3 slides.
Okay, yeah, I can finish.
Yeah.
No problem.
He has only 3 slides.
Okay. Okay, this was the case of periacetabular giant cell tumor, biopsy proven, and MRI showed the lesion as per this X-ray picture. The films of MRI are not available because I prepared this slide only today only, and I could not search those MRIs. So this was done around 10 years ago. So in this case, we did type 1, 2, and type 3 resection. So next slide, please.
Okay.
Yeah, so this was the resection done, and the head was wrapped around with a simple proline mesh, and soft tissues were tied around. And this patient, if video is working, I think it is not working. This she is able to walk.
It's working.
This is thank you very much. It is working very good.
Excellent, Dr. Kundu. It's really good.
It takes time, but it is working.
Yeah.
Nice.
This is also
so without any reconstruction, it is not feasible to reconstruct it. So it can be just a resection and flail hip, that a hanging hip. Another video also if it is feasible.
So it's not working. This video is not working. This video is working.
Next slide, please.
Yeah.
Okay. Just to show it, without reconstruction, in our circumstances, these patients. Next slide, please.
Yeah.
Next slide. She is able to squat and she is able to do all works. So this is a very simple thing. Resection. Now denosumab is also available. This patient is having 10-year follow-up, and she is doing all her household chores very well, and she is very happy. She can squat, she can cross legs it. So this is a very simple and without any prosthesis, less complication. So this is a simple procedure, just to show that. Thank you.
Thank you, Kundu sir. Fantastic case.
Thank you.
Okay.
Yes.
Okay, Mandeep, now is visible.
Yes. Okay.
Now
it was a great webinar. Very well arranged cases. Good cases.
Thank you. I will have first final words from Dr. Ashish and message from Tata, and then Dr. Agarwal, and then we'll have a closing ceremony.
Please put my video on now.
Yes. I am putting one by one. I am putting, sir.
Thanks, Mandeep. And I think first of all, I would like to thank Dr. Navin Thakkar.
Thank you.
It's just not about Gujarat Orthopedic Association, but I have been seeing his superb effort in past 6 to 8 weeks. We all knew that he is tech freak, and he had contributed a lot to IOA website and other things. But the kind of efforts which he has put and the amount of time which he has put to put all this showcasing, which not only helped orthopedic oncology, but helped every single branch of orthopedics to propagate knowledge all across, which is absolutely freely available to everyone. And I think it's a tremendous effort. I would like to congratulate and really clap for you for the effort.
And it is reusable, it is recorded, so anytime you can see it.
Yes. And actually, I took a clue from him, and then I spoke to Ashok Sham, and I started doing TMH ortho-onco classes as well, which was a great success also, where many people have also joined. So thanks to you. Thanks to Mandeep for putting this great show. I know we are discussing GCT again and again, but it was a tremendous effort. We did the benign tumors earlier, and we again come back to GCT. I think all our viewers will be extremely happy, because giant cell tumor is one which right from the beginning creates a lot of confusion, right from the diagnosis, what sort of treatment. And I think this is one tumor where there is enormous or maximum amount of controversies. And you have put great effort to put those controversies at rest. My take-home messages will be that please ensure that you do a correct diagnosis before you embark on any sort of treatment. Please understand that principles are more important than how do you execute or what you use to finish that job. So please remember the principles first. There is no right answer for you cannot have the same answer for every question. You need to tailor it. Today's era is of tailoring personalized medicine. You need to tailor your therapy, your plan of management, your plan of reconstruction to each and every patient. And please feel free to call your friends for advice. There is no shame in that. There are a lot of people now who's doing phenomenally good work, and they will guide you whether you can do it. And if you can't do it, please feel free to refer. You can learn with that. They will give amazing feedback. In addition to that, please also remember that tumor is a branch where you can get maximum medico-legal cases. So this is just a caution and advice that, if you cannot handle something, please refer these cases and take advices. And I think all the panelists have done a great job. And I will again congratulate everyone for contributing, and thanks Mandeep for involving me here.
Thank you, Ashish.
Thank you, Dr. Ashish.
Agarwal sir.
It is not only my effort, it is a team of Gujarat Orthopedic Association. Everybody is working hard. And
Yes,
it is a team of contributors. Without contributors, it is not possible. Yes, Manish sir, please.
Agarwal sir, your words of wisdom for general orthopedic surgeons and even for us.
No, so I think Navin has been at it, and I've been seeing that Orthopedic Association has probably done the maximum number of these educational webinars. I see something is there every day. And as Navin said, I think this is a gold mine of knowledge for anybody who wants to learn from it. If they've not been able to attend it live, at least they can go back and see it. I think we are entering something new because of this coronavirus. We are all learning the power of web-based education, which is now going to be here to stay. As far as this webinar is concerned, I think giant cell tumor is something which the average orthopedic surgeon sees a lot of. And there is a lot of confusion about what is correct. And it is very important to set the rules, the principles. And I think this goes a long way right from the beginning about looking at the x-rays, doing imaging, doing the evaluation, understanding the principles, and then finally working out a proper solution which works both for the patient and which is possible and practical to do at the site where the orthopedic surgeon is. And again, I agree with Ashish. I think it's an era, we are in an era where we are sharing, we are not isolated.
Yes.
We are isolated by the virus, but we are connected with everybody. So we must get a proper opinion. I think before we decide anything that we do for a patient, if there's any element of doubt, I think the whole principle has to be what best can I do for my patient? And it starts by getting an opinion of what better can be done and then going and executing that. So I think that's a very, very important message from this. It's not about whether I can do it or you can do it. I think finally the patient becomes the most important person and we need to do the best for them.
if you allow, because 5 or 6 questions are remaining from the audience.
sir.
We should
Yes, sir.
respect
Yes,
the
sir.
audience. So
Absolutely.
I'm just asking the question to you. In the lower end radius, Dr. Harshil Parekh from the Rajkot is saying, when does the vascularized proximal fibula is better than non-vascularized fibula graft, and when the fibula is used for Campani grade 3 GCT distal radius reconstruction, do you need to reconstruct ligaments with the palmaris longus graft?
Do you want me to answer
Yeah,
this
yes,
question?
sir. Yes, sir. Now all questions will go to you only.
Yes, sir. So I never use the fibula. I
Okay.
never use the fibula because I feel that the ulna which is present locally is the best graft to replace the radius. It's not only you don't have to take another incision. There's no donor site morbidity, and it is a vascularized graft. And the results that you get with an ulnar translocation are as good or even superior to the ones that you get with trying to do a fibula graft and an arthroplasty. I think it's something which now the whole world understands that it's important to do a fusion rather than do an arthroplasty, because the long-term results with an arthroplasty tend to fail over time and you tend to get subluxations and pain. Some of them do well. Yes, there are isolated cases which have been shown today by the panelists which have done well, but a lot of them would fail. So ulnar translocation is a great way of getting consistent and reliable results. I think it has been something which has been developed in India. And as Indians, I think we do more of these rather than following the age-old fibula procedure. I think those are outdated now. And I know a lot of people from abroad who have started using the ulnar translocation now. And they all agree that I think it's superior to using a fibula. So I think we should stop using the fibula unless we don't have the ulna which is available to do a.
Okay. There are 3 consecutive inputs, probably from Dr. Kumta only. Dr. Yogesh, you talked about different dosing of the denosumab in case of eventual planned curettage. Please share your protocol with reference, if any.
Yeah, so what we are now doing is that if curettage is our option for treating post-denosumab, in order to reduce the difficulties of, or rather reduce the local recurrence rates, which are pretty high after using denosumab in curettage, what we do is that we give about 15-day interval injections of denosumab, 120 mg subcutaneously. It could be either 2-weekly or 3-weekly interval. And we use only 2 or 3 doses of denosumab and reassess 2 weeks after the last dose, and then go ahead with the planned intralesional curettage. What we have noticed is that we get a decent amount of result for which we have been wanting to use denosumab in these particular cases. And we also reduce the high rates of local recurrence, which result, we have seen reports about 35 to 40% of local recurrence rates post denosumab after we do a curettage. So we have been able to do a reasonably good amount of curettage, aggressive curettage and we have been able to remove most of that fibrotic component of giant cell tumor after we use limited dosing and not the conventional dosing.
Okay. Again, Dr. Kumta probably said, absolutely agree with the Manish. Denosumab is contraindicated in radiation treated cases. So he endorses the view. And further, he says that you can continue denosumab on an intermittent basis if she does not want surgery. That about the pelvis or sacral case. We have 2 patients in remission for 5 years with intermittent denosumab.
Okay, good input. Thank you.
Dr. Ashish wants to say something.
Yeah, so I would like to agree with Shekhar, what Shekhar said, that and this is what the genesis of a few trials which are already registered in CTRI, and because the denosumab is human monoclonal antibody, it acts like immunotherapy. And I have raised this point earlier as well, that the purpose of immunotherapy is not to kill. The purpose of immunotherapy is more related to epigenetics and to change the environment and the milieu where it works. And this is where we need to work and look at the decreasing the dosages required and increasing the frequency. And I think, India or the Asian countries are the basis where multicentric trials can be done. There are already some trials that are already started, but because I think none of the Indian institutes are part of it, because we see so many giant cell tumors, this is one food for thought that, what should be the accurate dose. From 120, it should be reduced to 90 or maybe 60 or maybe 30. And what should be the frequency? These are two unanswered questions which are still there for denosumab.
Okay. And one question was from Dr. Mukhi of using that some knife. I think it was a laser knife or something can be used to resection of that GCT rather than a cautery or something like that. I exactly do not come to know because many messages come.
Okay. Is there any question left?
It is a mesonex burr. Mesonex burr. What is mesonex burr? I don't know. He has given input, Dr. Mukhi.
Midas Rex.
Okay, it's a Midas Rex. It's the same.
No, it's basically a high-speed burr, sir, with a 70,000 RPM speed.
Oh, he has used previously mesonex knife as a word. So I was confused. Okay. I think almost all questions are answered. If any questions are remaining, just send us. We'll pass on to Dr. Mandeep, moderator, and he will get the answer, and we can put these answers, remaining answers. We have put previous webinar also, that answers we can put on that same web page, same link. So you can see the answers which are unanswered. Okay?
Yeah.
That can be done to save the
Thank
time.
you.
So we are very much thankful again to all the faculty, and I'm just stopping the live stream, and then we can have a 1-minute chit chat, and then we can go.
I will again thank